out. Dr. Ambili Jose,
Yes, sir.
can you please correct your name in the Zoom? It will be easy for the judges to mark.
Sure.
Dr. Anvika is fine. Dr. Balveer Kaur,
Not joined yet.
not one. Have you called them up?
Yes, ma'am. All 6 of them.
Dr. Malina is fine. Dr. Sana. I can't see Dr. Sana.
Ma'am, not joined.
So Dr. Shahida is the first one, Dr. Shahida Nagma. Fine. Himanshu, what about?
Hello.
Himanshu?
Yes, ma'am.
Dr. Anju wants the invite on the mail again. मैंने WhatsApp किया उनको, but एक बार दोबारा भेजो.
ठीक है.
Hello. Yes, we are ready.
Hello,
Hello.
Riddhi ma'am.
Yeah, I just wanted to ensure that I'm audible.
Yes, ma'am, you are audible.
All right. Thank you very much. Thank you.
We have 1 minute to go now.
There are the judges haven't logged in, all of them.
Ma'am, Dr. Anju and Dr.
12 o'clock.
Dr. J.K. Goel is there?
Uh,
No, he's not there.
Am I audible? I'm
Yes.
audible. Dr.
Yes.
Anju Mathur from Jaipur.
Hi, ma'am. Good afternoon.
Good afternoon.
Dr. Ritu has joined.
हो गया उनका ठीक है so J.K. Goel is not attending, but Anju ma'am, you have the sheets for marking.
Yeah, I have the sheet.
Dr. Ritu आपके पास भी है?
मैम अभी वॉइस से ज्वाइन नहीं हुई है.
I have just messaged Dr. Ritu the sheet also again, so I was just wanting to check it.
Ma'am, shall we go live?
To Dr. J.K. Goel just said I'm joining, so let's wait for 1 more minute.
I'm joined, ma'am.
Joined? सर ने join कर लिया?
Yes, ma'am. But they have not joined through their audio. Now join.
Okay, we can go live.
So, ma'am, we will be Yash. Yes, we will be going live in 3, 2, 1. Ma'am, we are live.
Good afternoon, everyone. I would like to welcome you all to 17th National Conference of Indian Fertility Society Fertivision 2021. This is a 3-day academic extravaganza, and we'll be starting with the poster session first. For the poster session, we have eminent judges with us, Dr. Anju Mathur, she is Medical Director, Mangalam Hospital, CFS Morphis, Mangalam International IVF Center from Jaipur. Welcome, ma'am. Dr. J.K. Goel, Professor and HOD at Saraswati Institute of Medical Sciences, Hapur. Welcome, sir. Dr. Ritu Prasad, Consultant in Fertility and Morphis Prasad International IVF Center, Dehradun. Welcome, ma'am. So in this session, we have young researchers presenting their work in form of an e-poster. And the time limit would be 5 minutes for the presentation and 2 minutes for the discussion. First, we have Dr. Shahida Nagma for isolated tubal torsion, a rare differential of acute abdomen.
A very good afternoon. Good afternoon, respected judges. So, I'm going to present a case report on isolated tubal torsion, which is a rare differential of acute abdomen. While torsion of the adnexa is a fairly common cause of acute lower abdominal pain in women, isolated fallopian tube torsion is very rare, with an incidence of Yes, ma'am. With an incidence of 1 in 1.5 million women. So, uh, because isolated fallopian tube torsion lacks specific symptoms, clinical observations, and imaging characteristics, laparoscopic examination is necessary for a correct diagnosis. So, herein we are presenting a rare case which occurred at our setup. The patient was a 24-year-old nulliparous woman, and she was asymptomatic completely a day prior when she started experiencing severe lower abdominal pain, which was associated with mild giddiness. Pain was not associated with nausea or vomiting. There was no history of fever, and pain was gradually increasing in intensity. There was no aggravating or relieving factors. When she was received in our ER department, her vitals were stable. She was conscious, well oriented to time, place, and person. Her systemic examination was also normal. On per abdominal examination, tenderness was present in the left iliac fossa, and during the initial examination at our department, a transvaginal ultrasound was done where a well defined cystic lesion was identified, measuring approximately 3.6 into 3.6 and into 3.3 centimeters. Um, and on the left side, the left fallopian tube was mildly dilated and appeared twisted with hemorrhagic contents within it. A provisional diagnosis of a twisted left fallopian tube with cyst in the POD was made. All her blood investigations were within normal limits, and there was no increase in the inflammatory response. Hence, decision for a laparoscopic examination was taken. At laparoscopy, the uterus appeared normal. The left fallopian tube showed torsion with 7 to 8 twists along its long axis, and it was bluish in color. So once it was detorted, the tube regained its pink color, and it was noted that it was around 15 centimeter in its total length. Alongside a left paratubal cyst of 3 into 3 centimeter size was identified. The cyst contents were drained, and the cyst wall was sent for examination. The left fallopian tube was plicated at three parts. The proximal part was plicated to the ovarian ligament, the mid part was plicated to the infundibulopelvic ligament, and the distal part plicated to mesosalpinx. The left ovary and the right adnexa, including the tube and the ovary, was completely normal. Patient was discharged on post-op day 3 in in stable condition. So, coming to the discussion now, the adnexal torsion accompanied by ovarian tumors is not rare, but isolated tubal torsion is rare, as I mentioned, and incidence is 1 in 1.5 million women. The predilection age of tubal torsion is in the reproductive age group between 20 to 50 years, and reports suggest it is more common on the right side, possibly because of the partial immobilization of the partial immobilization of the left tube by its proximity to the sigmoid mesentery on the left side, and relatively less venous flow on the right side. So, based on anatomical differences and the pathogenesis behind isolated fallopian tube torsion is not clear as yet, but considering its etiology, an idea has been proposed to classify internal and external factors separately. The internal factors refer to the causes within the fallopian tube, including hydrosalpinx, fallopian tube tumor, post-tubal ligation, abnormal progression of tubal peristalsis, while the external factors refer to the effects of the adjacent organs, including intraperitoneal adhesion, pelvic congestion, pregnancy, spasm of the fallopian tube due to medications. So, in the clinical symptoms which the patient present with is usually vague. They usually experience flank pain, and therefore the diagnosis can be confused with acute appendicitis or rupture of ovarian tumor or ovarian torsion, ectopic pregnancy, endometriosis, PID, and so on and so forth. So, general imaging is useful. General imaging can be useful to discriminate the causes of acute abdominal pain. However, it is very rare to diagnose isolated tubal torsion on pre-operative imaging finding. So the definitive diagnosis is usually made on visual eye examination, laparoscopy, or on laparotomy. So if adenitis is suspected based on clinical findings, in addition to a history of hydrosalpinx tubal ligation or dilated fallopian tube, so it can be supplemented by imaging modalities like transvaginal ultrasound with color Doppler. And a pre-operative definite diagnosis is difficult, but it is very essential to save the functionality of the tube. And timely intervention can help in saving the tube. And so since our patient was a young female, and early diagnosis helped in intervening and saving her uterus and her future fertility. Thank you, ma'am.
The judges can start with the discussion with Dr. Shahida, please. Dr. Anju? Ma'am, you are mute. Dr. Anju, you are mute, ma'am. Dr. Anju Mathur, ma'am, you are mute. Yes, ma'am.
Why did they mute me? I thought because I was just trying to. Anyway, that was a very nice presentation, doctor. I
Thank
just
you, ma'am.
have two queries. What was the LMP of the patient?
Ma'am, her LMP was 14 days prior. She was in the mid cycle. Yes,
Exactly. Okay.
Yes,
So the DDs that you have given, they are general DDs. Any specific differential diagnosis for the torsion of fallopian tube?
ma'am, apart from that, we suspected adnexal torsion, ovarian torsion, we were suspecting in her case, but she never had.
You said the vitals are normal and the investigations are normal. Right?
Yes, ma'am. Yes, ma'am. Yes, ma'am.
So how did you decide for laparoscopy with everything normal in a diagnostic district, in a nulliparous?
Yes, ma'am. Ma'am, actually, when the transvaginal scan was done, so the Doppler, when the color Doppler was put, it was showing an extra ovarian torsion. The flow was more towards the tubes, and there was just a separate cyst which was seen, which was a clear cyst, and the ovaries appeared completely normal, ma'am, in location as well as their blood circulation. So based on the transvaginal.
Only on the transvaginal ultrasound you have taken up a laparoscopy.
Yes,
Her
yes,
TLC
yes,
was
yes.
normal, her vitals were normal.
Yes, ma'am. Yes, ma'am.
She was, you didn't consider taking her for, okay, that was a torsion that was a diagnosis made after the laparoscopy.
Yes,
But
ma'am. Yes, ma'am.
you see a patient in the OPD with everything normal, it is a little difficult to take for laparoscopy. So, any other investigation which could have, yes, TVS was showing torsion.
Yes, ma'am.
Anything else?
And no inflammatory marker were raised in her case, ma'am. The TLC was normal. The CRP was also normal. And she, yes, ma'am.
Okay. Dr. Goyal?
Actually, in these cases, the LMP, I was not there, but does there any relation with the menstrual cycle and all? Is it more that after periods or any relation with the periods? The torsion of that fallopian tube?
So there was one case report reported in 2019. They said that it is more common during the mid-cycle because of increased peristalsis and increased blood flow. But no other reports have suggested any particular relationship with the menstrual cycle, sir.
And didn't you go for that pregnancy test and all? Or it was
Yes,
not?
sir. Yes, sir. It was
negative.
Yes, sir.
It was negative.
Yes, negative. Negative, sir.
And only that alternative after TVS, even if you are in doubt, you have to put a scope because it will be therapeutic also. Even if you are thinking of any other pathology also, you have to see and put a laparoscope. Scope has to be diagnostic. Laparoscopy is the only answer. That is diagnostic also, and most of the case they are therapeutic also. That is correct. Very good. Rarest of the rare.
Yes, sir.
Only in 1.5 million. Thank you. Good.
Yes, sir.
Congratulations.
Thank you, ma'am. Thank you, sir.
So we move on to our next participant.
How many of the participants are there?
So we have 6 participants.
अच्छा, उनके नाम भेज दीजिए मैडम क्या?
हाँ जी सर, मेल पे आपके आप कहते हो तो मैं एक बार दोबारा भेज देती हूँ, आपके व्हाट्सएप पे भेज दो.
हाँ व्हाट्सएप पे भेज दो मैडम.
बिल्कुल सर. So next we have Dr. Ambili Jose. She'll be talking on gonadotropin resistant ovarian syndrome, a diagnostic and management challenge.
A very good afternoon, everyone. I am Dr. Ambili Jose, an FNB resident in the Department of Reproductive Medicine, Kraft Hospital and Research Center, Thrissur, Kerala. I am here to present a very interesting case which posed a diagnostic and management challenge to us. This was a case of a gonadotropin resistant ovary syndrome. So what is it? The association of amenorrhea, gonadotropin levels at the menopausal range with a normal AFC. It's a rare condition which evokes an ill-determined trouble of folliculogenesis. This was first reported in 1969 as resistant ovary, or the less popular Savage syndrome. Now, the objective of my presentation today is to demonstrate the successful diagnosis of gonadotropin resistant ovary syndrome and the management in a 28-year-old patient with irregular cycles who presented to us. She was misdiagnosed previously as premature ovarian insufficiency because she had multiple FSH reports, more than 30 to 40 international units per liter. And she's also had 2 cycles of controlled ovarian stimulation, wherein the cycle had to be cancelled because there was absolutely no response despite recombinant FSH of 300 international units for up to 18 days. There was no growth and the cycles were cancelled. Now to note, this was despite an AMH of 9.6 nanogram per ml and an AFC of more than 40. So when the patient came to us with this diagnosis in mind, we started her on an antagonist protocol with a dose of recombinant FSH 300 and a highly purified HMG of 75 international unit. Now, after an induced menstrual cycle, on the starting day, her FSH was still 27.9, LH was 14.28, estradiol of 29. We gave her injections for around 17 days, and on the final day, stimulation day 17, the E2 was still only 20, and there was no follicle of more than 6 millimeter. Now, as per our IVM protocol, we gave her a trigger with recombinant HCG, that was Ovitril 250 microgram, decapeptyl, and a urinary HCG of 5,000. Oocyte retrieval was attempted after 40 hours, and we aspirated 3 COCs, which were cultured in an IVM medium for 24 hours. After 24 hours, a denudation was done, and ICSI of 1 M2 and 2 M1s were done on the second day. We managed to obtain 1 moderate day 3 embryo, which was cryopreserved, as the patient wanted an embryo accumulation and further COS. Now, what is the aim of this presentation? This is to highlight that the presence of a presumed premature ovarian insufficiency in patients who are seeking fertility treatment, we should always be careful in considering a complete differential diagnosis, including the diagnosis of a gonadotropin resistant ovary syndrome. This is definitely a very rare entity with only 3 live births being reported worldwide with IVM. But in case of premature insufficiency, there is generally a concordance among your FSH, AMH, and AFC. However, in cases such as us, where there is a discordance between the ovarian reserve markers, where the FSH was high, but AMH and AFC were normal, a diagnosis of gonadotropin resistant ovary syndrome should always be considered. And in such patients, such as ours, who is advised donor oocyte, in vitro maturation, which is already a fertility option, should be offered as a first-line therapy before resorting to the use of donor oocytes. Thank you.
Very good.
That was a very nice presentation, Dr. Emily.
Thank you.
Very rare this thing. So that is, so how should we differentiate in a resistance gonadotropic case and the POF? That is by finding the, how will you differentiate?
Yes, ma'am. In the
key points to diagnose them is?
Yes, ma'am. In the women whom we categorize as hypergonadotropic hypogonadism, that is WHO class 3 anovulation, I would suggest that we should also look at the AMH and not just the FSH levels. The patients present similarly in the clinical scenario, but the patient will have normal secondary sexual characteristics, irregular cycles, progressively prolonged. but the AMH levels and the AFC levels would be normal in this rare case. Despite
And what was the incidence that you found in the literature?
And there are only 5-6 case reports. There are only 3 live births. The first reported was in 2013. All 3 live births by in vitro maturation.
Live births is all right, but how many of the cases we were able to take out?
Only around 10 reported cases, ma'am.
Only 10 reported.
Yes.
Okay. So, do you think there can be any other marker which can diagnose it besides the regular this thing that can help us diagnose? And what was the phenotype of these patients? Anything, any history which can relate to this? These kind of things.
Hello, ma'am. Sorry, the connection. Yes, ma'am.
I'm asking, was there anything specific in the history?
Ma'am, this patient had no family history suggestive of anything related to a genetic cause. The literature suggests that there could be, this could be a very rare variant of an FSH receptor polymorphism, which routinely presents with an FSH of around the range of 10, and they're just normal hyporesponders. But if there are compound mutations of the FSH receptors, or there is also an association with autoimmunity, we tested the patient for general anti-TPO, anti-thyroid antibodies. The anti-adrenals were not sent, and an FSH receptor was offered to the patient, but the patient refused because she felt that the management wouldn't change much because we were giving her maximal dose of gonadotropins.
Okay. Excellent. Very good.
Thank you so much, Dr. Ambali. Moving on to our third participant.
Excellent.
Thank you, sir. Thank you, ma'am.
Dr. Anvika Kapoor. She'll be presenting on correlation of mature mean follicle on TVS and serum estradiol levels on day of trigger injection of ovulation in ovarian stimulation cycles of IVF with retrieved oocytes.
Good afternoon, everyone. So my topic for the e-poster is correlation of mature mean follicle on transvaginal ultrasound and serum estradiol levels on day of trigger injection of ovulation in the ovarian stimulation cycles with retrieved oocytes. So controlled ovarian hyperstimulation aims to obtain mature follicles. My study was conducted to assess the correlation of mature follicle in TVS and serum estradiol levels on the day of trigger injection in ovarian stimulation cycles of IVF with oocyte yield. In this prospective study, we evaluated women between 19 to 45 years of age who underwent IVF cycles. So these women were included. The study
Slide is not that legible because of the very small size.
Dr. Anvika, what is showing on the screen is outcomes of vaginal sildenafil and ART.
No. This is a wrong, I think, wrong presentation. For tomorrow's, has come for today.
Oh, so do you have it right now? We'll make you the host. You can share it on your own, Dr. Anvika. Himanshu, please make her the host so that she can share her poster.
Ma'am, she can share.
Thank you. Or Dr. Anvika, in the meanwhile, you figure out we can go to Dr. Balveer Kaur.
Okay.
Fine, judges.
Yes.
So, next is Dr. Balveer Kaur. She'll be presenting on primary amenorrhea associated with endometrial tuberculosis.
Can you see my presentation?
Yes, we can.
If she's ready, we can go ahead with her.
Okay. Dr. Anvika, please go ahead.
So my topic for today is correlation of mature mean follicle on transvaginal ultrasound and serum estradiol levels on day of trigger injection of ovulation with stimulation cycles. So in this study, we to evaluate oocyte donors between 19 to 45 years of age who underwent oocyte retrieval. Number of mature follicles visualized on last day of TVS scan on stimulation, it was noted, and serum estradiol levels were noted with the follicles and oocyte retrieved. So in this study, antagonist protocol was used for ovarian stimulation. The starting dose of gonadotropins like FSH and HMG was individualized according to age, antral follicle count, and AMH BMI levels. For both protocols of IVF, the dose was adapted according to ovarian response to treatment. In antagonist protocol, flexible regimen was used. Cetrorelix 0.25 mg was added once follicle reached 14 mm of size, and final oocyte maturation was achieved with 0.2 mg decapeptyl injection trigger when at least 2 or more follicles reach a diameter more than 17 mm. Serum estradiol levels were noted and then were correlated with oocytes retrieved. So in this study, mean age of patients were 27 years of age, BMI 26 years of age, and mean FSH was 6.8. On the day of trigger, mean mature follicle count on TVS was 20.4, ranging from 8 to 50. Average oocytes retrieved was 17.2. On the day of trigger, estradiol mean was above 4,000, ranging from 500 to 15,000. It was observed that number of retrieved oocytes were correlated significantly with serum estradiol levels and with the number of mature follicles on the last day when the trigger was put. So the present study demonstrated a significant positive correlation between serum estradiol levels on the day of trigger and number of mature follicles seen on TVS with the number of oocytes retrieved. There are few limitations for this present study. First of all, a very small sample size was used and the subgroup analysis were very small. Secondly, we did not analyze the embryo quality for the live pregnancy results. Thank you so much.
Dr. Goyal?
Madam,
And we have Dr. Ritu also.
Dr. Ritu?
What was the correlation seen? Does it correlate well with that?
Yes, sir.
Size of the number of follicles, size of the follicles with the estrogen's level along with that oocyte retrieved. Does it correlate?
Yes, sir. There was a positive correlation between both of them, and the live pregnancy results were also there.
Ritu? Dr. Avnika, that was a very nice presentation. But the reference, the age, what was the age, this thing that you have taken, that is a very big, from the young.
Because ma'am, we used to have oocyte donors. So for that, the age difference was there between 18 to at least 40 years of age.
That's a very, very, big difference.
Yes.
But that's a very wide age limit that we have taken. So for that, you have found that it is correlating with the estradiol and the number of oocytes.
Yes, ma'am.
So that is excellent if you have found, but sometimes we don't get that actually.
Yes.
So what are the reasons that you don't get it? Now you have shown that it is getting it. What can be the reason that you don't get it?
So,
ma'am, don't correlate.
Yes, ma'am. So, ma'am, many of the times, like the studies which I have seen, some studies show that there is a relation, and some studies show that there is no relation between both of them. So, in those studies, it was mentioned that above 4,000, if the estradiol levels are there, so it always affects the endometrial receptivity, which is always present, and so there are negative outcomes because of that.
So, in all the cycles, you have done breast transfers.
Yes, ma'am.
Because you are saying live birth rate. Yes. So you have done fresh transfers.
Yes.
But how many donors were there in the study?
Around 25.
25 donors were there.
Yes.
Dr. Ritu? She was asking to unmute Rhythm.
Dr. Ritu can unmute herself. I mean, we haven't muted anyone from backend.
Okay, sir. I think if she is not there, then we can move ahead with the next one.
Sure, ma'am. So next we have Dr. Balbir Kaur. She'll be presenting on primary amenorrhea associated with endometrial tuberculosis compounding polycystic ovarian syndrome case report.
Good afternoon, everyone. I am Dr. Balbir Kaur, fellow in Vasundhara Hospital, Jodhpur. Today I'm presenting a case report, primary amenorrhea associated with endometrial tuberculosis, compounding polycystic ovarian syndrome. The study question of my study is that does PCOS or endometrial tuberculosis or their association can cause primary amenorrhea? So we had a 37-year-old woman who presented with the complaints of primary amenorrhea and subfertility. She had history of genital tuberculosis 12 years back, diagnosed during evaluation of primary amenorrhea. Endometrial biopsy revealed epithelioid cell granuloma suggestive of endometrial tuberculosis. She was treated with anti-tuberculosis drugs for 9 months, but she continued to be amenorrheic. 3 years ago, she was diagnosed to have diabetes mellitus and she was put on metformin and glimepiride combination. In her family history, her mother was diabetic, her BMI was 27.25, her secondary sexual characteristics were well developed, and per speculum per vaginal examination were normal. At the age of 25 years, she was diagnosed to have endometrial tuberculosis and received ATT. And 34 years, she was diagnosed to have diabetes. At 36 years, her hormonal profile and USG revealed PCOS. Again, in 2019, she was hysteroscopic adhesiolysis and septal resection was done, and her glycemic control was achieved with the drugs. At the age of 36 years, she attained menses after biphasic estrogen and progesterone pills, and she was put on OCPs for the 3 months. In 2020, at the age of 37 years, her day 2 TVS revealed AFC 4 to 5 in bilateral ovaries with thin endometrium, underwent IVF in view of tubal blockage and male factor subfertility. Her hormonal evaluation revealed PCOS. On evaluation, her pelvic ultrasound revealed small uterus with thin endometrium and irregular cavity with the bilateral polycystic ovaries. Her hormonal profile was also consistent with the polycystic ovarian syndrome. She was given biphasic estrogen and progesterone combination but did not respond, so she was planned for diagnostic hysterolaparoscopy. Hysteroscopic evaluation revealed atrophic endometrium, intrauterine adhesion, and thick septum in the uterine cavity. Laparoscopically, finding was suggestive of bilateral thick and blocked fallopian tubes. A case of primary amenorrhea needs proper and methodological evaluation. History-taking physical examination should be meticulous. Early diagnosis of treatable causes of primary amenorrhea is key to fertility preservation. It is imperative to consider the possibility of genital TB in the women in reproductive age group who present with the symptom of infertility, chronic pelvic pain, and menstrual dysfunction, where other causes has been excluded, especially in the rural settings. Hysterolaparoscopic evaluation aids in the diagnosis and the treatment of endometrial pathology and improve the chances of restoring endometrial function and fertility outcome. This case highlights the need for prompt and efficient referral in the patient management. In our case, even diagnosis of the genital TB was made earlier and ATT was also given, but patient lost follow-up due to lack of awareness. Over the course of the time, patient developed diabetes mellitus type 2, which could be the late manifestation of undiagnosed PCOS. Unevaluation along with the post-tuberculosis scarred endometrium lead to prolonged primary amenorrhea in this patient. Thank you.
That was a very nice presentation, Balvi. Tuberculosis
Thank you.
is a very, very common thing, especially in Rajasthan.
Yes,
and I'm sure it is in the other parts of the country also. So what I cannot understand is that she was diagnosed to have tuberculosis in her mid-20s and then she was lost to follow-up, right?
Yes, ma'am. When she came to us, she was 36 years. And that time, like...
She was still amenorrheic. She was still amenorrheic.
Yes, ma'am.
Okay. So when she was lost to follow-up, then... Okay, what about her reproduction?
Like first we went for the laparoscopy. We did septal resection for her. Then we put her on OCP, so she got period with those OCPs. After that, she underwent IVF because of tubal factor infertility and the male factors of fertility also was there. But she did not conceive after IVF also. She did not conceive after first cycle of IVF also. Like we got only one.
Can primary amenorrhea be due to that PCOS, early onset PCOS?
Yes, yes, sir. It should be because of PCOS only.
How will you distinguish it, whether it is due to the tuberculosis or whether it is due to the...
Because she underwent, she took ATT for 9 months. after that also she did not get her periods.
If she comes to you, you don't know.
Yes, sir. Yes, sir.
You know that she has got tuberculosis, she has got that PCOS.
Yes, sir.
Differential. How will you clinically differentiate between PCOS and tuberculosis, endometrial tuberculosis?
Yes, sir. On examination, her hormonal profile was conclusive of PCOS.
Just giving progesterone challenge test.
Yes, yes, sir.
Challenge test will be positive in cases of that PCOS.
PCOS, yes, sir.
Whereas the endometrial level.
Yes, sir. In tuberculosis.
Endometrium, that it won't be that there won't be any withdrawal.
Yes,
even with estrogen, progesterone also it will be not there.
Yes, sir. Yes.
On ultrasound, TVS ultrasound also we can differentiate between the PCOS and the tubercular endometritis.
Like she has the both findings, like she has PCOS, like PCO ovaries along with the thin endometrium and the small uterus, with the multiple additions were seen on the TVS. So that's why she went for hysteroscopy. And
what was the aim of taking this patient for the presentation?
Like it is a rare case report along, like primary, because patient has primary amenorrhea. Usually patient doesn't have primary amenorrhea, they have secondary amenorrhea or scanty menses with the PCOS. So PCOS leading to the primary amenorrhea is a rare case. Because of that, I took this.
What is the trigger for reproduction?
Very much common. Dr. Anju,
So,
this case is very much common. Here in Uttarakhand also, we are seeing many patients from areas which are coming with their same complaint of amenorrhea, PCOS and tuberculosis. And also many times tuberculosis and endometriosis are also there. Both can exist.
But amenorrhea till the age of 24 actually is a neglected part. Till the age of 24, primary amenorrhea is actually a neglected case and a very, very much.
What is future for her as far as reproduction is concerned? What do you plan for her?
More in favor of Mayer-Rokitansky syndrome. If she is having a primary amenorrhea.
Yes. She goes in favor of that. Madam, she must have not come, as she is saying that she was lost to follow up. So she must have
also
not.
uterus is also small, no? Uterus is
yes.
Sorry to interrupt, judges, but we are exceeding time for the
next case, please.
Can we move on to the next one, please? So we have Dr. Molina Patel. She'll be presenting on clinical outcomes in patients receiving alpha biosimilar to original folitropin alpha in real world scenario practice.
A very good morning to all the judges. Today I will be presenting my poster on this topic. Gonadotropins have always been in use since the 1930s in the treatment of infertility. But in today's era of individualized controlled ovarian stimulation, the selection of the right kind of gonadotropin in terms of its efficacy, quality, safety, biological profile, and at the same time, the effect it has on the embryos and the clinical outcome rates is very important, and that has led me to present today's paper. What we have done is we have compared the pregnancy outcome, live birth rate in patients undergoing ART using Gonalev and other biosimilars compared to Gonalev. It was a retrospective observation study between 2016 to 2020 that was conducted in a tertiary ART center, and the population that we studied was comprising of women undergoing ART who were administered biosimilars or Gonalev, and a total of 174 and 190 women were studied in each of the arms respectively, and they were analyzed. It is a retrospective cohort study where the entire 364 infertile women population was taken. Fresh or frozen blastocyst transfers was done, and the primary endpoints that we had studied were clinical pregnancy rate, miscarriage rate, live birth rate, preterm birth rate, as well as and statistical analysis was done for all of the parameters. As we can see in the slides, the number of embryos in each of the groups, there was a significant outcome. When compared to 4.34, the mean outcome of the number of embryos was 4.34 in the Gonalev category and only 3.46 in the biosimilar category. Similarly, there was a significant difference in the number of good quality embryos that were yielded in the two groups. that is a mean of 83.8 in the GONAL-F category and 60.47 in the biosimilar category. The clinical pregnancy rate also statistically differed, that is 66% in the GONAL-F category and 40.43 in the biosimilar category. And finally, the full-term live birth rate also differed significantly in both the groups. So we can now conclude that according to the results, the two cohorts, that is the group of patients that received GONAL-F as well as the group of patients that received the biosimilars, they were quite similar in demographically and baseline characteristics, except that the age was different, that is 32.5 years when compared to 29.97 years. AMH, that is 4.2 nanogram versus 5.1, and other hormones. The number of oocytes retrieved from the two groups were comparable, but there was significant difference found in the quality of the oocytes and the number of day 6 embryos. A higher percentage of women had good quality oocytes, particularly in the GONAL-F group. This is a level of significance stable in the group A. The group A here we are signifying as the number of women who are less than 35 years of age. So we can see that the number of embryos of day 6, the number of embryos that were transferred, as well as the number of good quality oocytes in both the patients in both the groups are statistically significant, with a higher number in the GONAL-F category. And so there was correspondingly a increase in the number of clinical pregnancy rate and live birth rates. Finally, I would like to say that to conclude, choosing between the biosimilar or the type of GONAL-F in our day-to-day real practice can be a real challenge. Ultimately, the final aim of ART should be a pregnancy leading to a live birth rate. Previously, there have been a lot of studies in which there are the GONAL-F as well as the biosimilars differ in their biological activity, in the composition of the isoforms, their glycosylation, as well as the clearance rates when they are given actually to the patient. There are a lot of studies that have shown that the glycosylation of the different forms of recombinant human FSH has a significant and a direct role to play on its effect on the oocytes, particularly in younger patients of less than 35 years of age. That is the profile that we have studied in our patients. In the light of the different glycosylation profiles of the various recombinant human FSH, other signaling pathways may also be involved, as we can see from our study that has an effect on the oocytes, and subtle differences in the final outcomes can be seen. So to date, no such study in the Indian profile has been done that has compared the recombinant FSH, that is the originator product, and the various other bioforms. And in this regard, this study will guide us whether in young patients, which particular recombinant FSH must be used in order to give the best outcome. And this will in turn be cost effective and reduce the time to pregnancy for our patients. Thank you.
That was a very nice presentation, Dr. Molina. I just wanted to know, you just used FSH, no other hormone was used?
Yes, ma'am. In both the prongs, only FSH was used.
Only FSH was used?
No HMG, no HMG.
No HMG. And what was the mean age in your group?
Ma'am, the mean age in the GONAL-F category was 32 years, mainly because the more worse profile of the patients were actually included in that category. Whereas in the prong B, it was slightly less, that is 29.5, but it was not statistically significant, so it could still be compared in the study.
And what was the mean M2 that was found in both this thing? Was there any difference in the M2? I'm not saying the live birth rate, I'm talking about the M2.
Yes, ma'am. The mean number of M2 oocytes also it was statistically significant, with more number of mature oocytes yielded in the GONAL-F category when compared to the biosimilars.
Okay. Okay. Thank you.
Thank you, ma'am.
Thank you.
Can we move to the next?
We are really using pure GONAL-F or pure poliotropin. We are generally using in combination with HMG. What's your take of Dr. Anju?
Yes. Oh, sorry, ma'am.
Yeah, Ritu?
Yeah.
What? I didn't get it. Sorry.
Actually, what we are using, gonadotropin combination with HMG.
Yes.
For
That is what I was trying to ask her, that but in the higher group only, that is in the fourth decade also, she has used FSH.
Ma'am, sorry to interrupt, madam. This particular study was only conducted in age group of less than 35 years of age.
Yeah, less than 35, but that is the fourth decade of life, right?
Yes, ma'am.
That is the fourth decade of life. What is academically, what do you feel is the right group to be given FSH? When you take a patient for stimulation, what is the right age to be taken for FSH?
Ma'am, the patients which are poor responders, patients who have polycystic ovarian syndrome, patients who are on the worst side of the spectrum may be stimulated with recombinant FSH. But in patients of less than 35 years, when we generally take it for granted that either recombinant HMG or recombinant FSH both should give good data and good outcomes, here we have purely compared the FSH so that we know what is the effect of the other biosimilars as well as the originator just on this day.
Did you take a column in the form of what were their FSH NH ratio?
Ma'am, we have done the mean ma'am, FSH LH ratio. Ma'am, we did the mean FSH as well as the mean LH individually.
So what was the ratio in your study?
Ma'am, that is there in the data that both of them were comparable. The mean LH.
Okay. Thank you.
Thank you, ma'am.
Thank you, Dr. Molina.
So moving on to our last participant in the session, we have Dr. Sana Nakash presenting on reproductive outcomes after intrauterine insemination in young women stratified by serum AMH levels in different protocol cycles.
Very good afternoon, respected judges and everyone else. I'm Dr. Sana Nakash, pursuing MCH in reproductive medicine at Mahatma Gandhi Hospital. This is a study that I would like to share in the form of a poster, and what our aim was to evaluate pregnancy outcomes following intrauterine insemination in young women with low ovarian reserve, and we compared this outcome with age-matched control. This was a retrospective cohort study that we conducted in our hospital, and what we essentially did was collect data of young women. Young women in our study were women who were less than 35 years of age. We collected data, we have electronic records of these patients, and we retrieved that, and these women underwent IUI at our hospital in the last year from July 2020 to August 21. And the women who were included in this study were essentially those who had no tubal factor infertility. They had patent tubes on the HSG. They had the male partners had a total sperm concentration of more than 10 million per ml. And essentially those women who had a primary diagnosis of endometriosis were excluded. So we did not take them into account. And what we did was classify these women who were less than 35 undergoing IUI in our center in the last 1 year. What we did was divide them into two groups. Women with a low AMH, the arbitrary cutoff that we took in our study was a level of 1.2 nanograms per ml. So these women were classified as low ovarian reserve with an AMH of less than 1.2 nanogram per ml, and the other group had women who again were less than 35 years of age but had a better reserve of 1.2 or more level of AMH. As you can see in table 1, we have the specific patient characteristics. The average AMH in the women who had a low AMH level was around 0.5, and in the other group it was around 5. Day 3 FSH, as expected, was higher in women who had a lower reserve. You can see there was a positive correlation between an AMH level and the baseline AFC that we saw on day 3 of these women. Age, they were around 32 in the group of a lower reserve, and 29 was the average age in the other group. So these are the patient characteristics in table 1. And what we essentially wanted to see was the primary outcome was to see a positive pregnancy. So a positive pregnancy would be 14 days after we do an IUI, a beta HCG of more than 20 milli-international units per ml was a positive pregnancy test. So that was our primary outcome, and as is very evident in the second table, there was no statistically significant difference between the two groups, and we were surprised in fact to see that. And the other secondary outcomes that we saw was a biochemical pregnancy or a clinical pregnancy loss, or in other words, a miscarriage, or the likelihood of an ectopic pregnancy, and then at the end, the live birth rate. And interestingly, there was no difference. There was no difference between the two groups. Women who were young, who had an age of less than 35, conceived, or rather had pregnancy outcomes that were comparable to women of the same age with higher AMH levels, and that was very interesting to see. And I mean, this led us to believe that in these women, so women who are less than 35, even if they have an AMH of less than 1.2, when we sort of stimulate them, and the superovulation probably the recruitment of follicles is probably more despite their lower reserve, and the pregnancy outcome is not affected by the AMH level. So that was a very interesting finding, and we hope, of course, to dig in a little more on this. But what we found was very interesting, and I thought I wanted to share this as a poster today. Thank you very much.
That was a very nice presentation, Sana. Congratulations. And so, what was the different protocols that you used? How many of them were given gonadotropin?
Ma'am, in terms of the treatment strategy that we use, we have a standard protocol that we use. We give 5 days of letrozole and HMG for 2 days. That is a sort of standard protocol that we use in most patients. That was what was given. And even after comparing the different treatment strategies, even the other patients who just received letrozole followed by IUI, or clomiphene followed by IUI, or gonadotropin followed by IUI, the results were comparable. There was not much difference in the outcome.
So the standard protocol was followed for all of these patients that you had taken for the study?
Yes, ma'am. Yes, ma'am. These were 110 women in whom a standard protocol for IUI was used.
And what was the percentage of positive results?
Ma'am, both groups had comparable results, around 10, 13 out of 40 in one group, and 15 out of 40 in the other group conceived. So the p-value was not significant when we compared them conceiving and their considering their AMH level. So the outcome was the same in both groups.
Outcome was the same. So that was excellent. Thank you. Any other, Dr. Ritu or Dr. Goyal?
Thank you. Good.
Dr. Sana, it was a nice study, but how come a standard protocol could be used for all 110 patients? That because many a times the in different patients the follicle is going at a different rate, so we adjust the dose and according to the patients when we do that transvaginal sonography. This I want to teach you also, because many a times the patient's variation is there. Many a times the endometrium is going out of the face, and follicle is slow. So we have to change the protocol as such that we cannot follow a standardized protocol, and as such the quality of the oocytes also varies with the AMH. Many times that if the AMH is on the lower side, the are not of very much good quality that can give a result. So AMH of 1.2 or 2 is more in favor of a good pregnancy rate as compared to low AMH in considering the IUI results.
Right, ma'am.
And I want to share with my experiences.
Yes, ma'am. Right. That's what we thought as well, ma'am, and that is what led us to dig into the data.
Nice study.
Yeah.
Yeah.
Yes.
And many a times when we are using a natural cycle for IUI,
Yes,
if
ma'am.
she has got a good E2 level of less than 40,
अरे मुझे बोला है कि मैंने उसका भी पूछा तेरे को मना करके मैं नहीं दिए पैसे
for this IUI, we don't need any stimulation. Naturally, the follicle grows because we need only a monofollicular follicle.
Yes,
The
ma'am.
patient is regularly menstruating, and for male factor, we don't give any stimulation. And many a times when we do IUI at proper timing, endometrium is normal, follicle is normal, then the patient conceives. There is no need of giving letrozole or gonadotropins in such normal menstruating patients. with a male factor in a case of IUI. I don't give any of gonadotropins or letrozole or clomifene. I just consider down regulation and proper follicular monitoring.
Right, ma'am. Right.
That gives a result.
That was a very nice presentation, Dr. Sana, because it is for students to know that AMH actually doesn't affect when the lower AMH and the higher AMH is actually not affecting the takeaway baby.
Reproductive outcome. Yes, ma'am. Yes, ma'am.
Thank you.
Thank you, ma'am. Thank you very much.
Thank you all the participants and judges for this very enlightening session. And with this, we'll wind up this session. Thank you, everyone.
Thank you.
Thank you.
The
Thank you, Dr.
judges
Anju.
are requested to mail back the marking sheet on the same address.
Thank you. Thank you. Sure.
Okay.
Thank you, everyone.
Thank you.
Thank you, Dr. Anju.
Thank you, ma'am. आगे लो, बंद करते हैं। अपलोड कर दो। मैं इसलिए नहीं लिखा कि मेरे पास सर में दिक्कत आ जाए।
Hello? Hello, am I audible? And are we going to start?
Good afternoon, ma'am. Another 1 minute we'll be starting, ma'am.
Okay, okay, thank you.
Rhythm, ma'am.
Yes, Himanshu, tell me.
Ma'am, shall we start?
एक second. Himanshu, I think we start.
Yes, ma'am, we can start now.
Good afternoon, everyone. I welcome you all to the 17th Annual Conference of Indian Fertility Society, Fertivision 2021. We move on to our oral paper session from the poster session. And to judge the session, we have Dr. Ruma Sathwik. She's consultant, Center of IVF and Human Reproduction at Sir Gangaram Hospital, Delhi. Dr. Kavita Agarwal, Associate Professor, VMMC and Safdarjung Hospital. Dr. Akshay hasn't joined yet. So I welcome you all to judge this oral communication session. First to present with us, we have Dr. Abhinay Sriram presenting on comparison of pregnancy outcome between modified natural cycle and hormone replacement cycle in patients who underwent frozen thawed embryo transfer, a randomized prospective study.
Rhythm, before we can start, could you give us an idea about how many minutes does the student have to
The
present?
presentation time is 8 minutes, discussion is 2 minutes. There's a timer that is on display. And once the time is up, the transmission will stop.
Right. Oh, thank you.
Hello.
Yes, ma'am, we can hear you. You can start.
Yeah. Good afternoon, everyone. Today my topic for presentation is comparison of pregnancy outcome between modified natural cycle and hormone replacement
Ma'am,
therapy.
we are not able to see your screen. Please start sharing your screen. Yes, ma'am. Now we can just make it slideshow.
So my topic is like comparing your pregnancy outcomes between a modified natural cycle and the hormone replacement cycle in frozen thawed embryo transfer. It is a prospective randomized study. And the study is a single center study with 2-arm open label trial, which was conducted in Women's Center by Motherhood Hospital, Coimbatore. It was around November 2020 to May 2021. And the study population included 60 patients who met the inclusion criteria and had 1 or 2 embryos, good qualities, either a blastocyst or a cleavage stage embryo belonging to a self or a donor gamete were included in the trial. It was under 2 groups, a modified natural cycle and the HRT. The inclusion criteria, couples with 20 to 40 years of age and had a regular cycle, and women who had their embryos cryopreserved for transfer. Exclusion is irregular menstrual cycle, and the cycles using pre-implantation genetic tested embryos, recurrent pregnancy loss, and uterine anomalies. So the patient were alternatively assigned to the natural cycle and the HRT cycle, and those who were allotted to the natural cycle were designed as group 1 and the hormone replacement as group 2. So the group group 1 had a modified natural cycle. The patients had their ultrasound done on day 2 or day 3, and again on day 10 until the day of the dominant follicle of their menstrual cycle. When the lead follicle was around 17, more than 17 or 18, an HCG trigger of around 5,000 international units was given, and the progesterone was started on day 3 of an HCG trigger. Either a day 3 or a day 5 embryos of 1 or 2 were transferred on days 4 and day 6 with the ultrasound guidance. The patients in whom the
Vinya ma'am, sorry to interrupt,
Yes.
your slides are not moving.
It's moving for me.
It is not in the slideshow mode. If you are seeing the slideshow mode on your screen, please stop share and do share again.
I have to stop and share again.
Yes, ma'am.
No.
Yes, now we can see.
Okay. It's not moving for me now.
Ma'am, click on the slide once.
Yes. So the group 2 had their HRT therapy, and estrogen was started. Estradiol valerate was given at a daily dose of 4 to 8 milligram from day 2 or day 3 of a cycle. It was given for 14 days, and their endometrium was rechecked for their thickness, and it was more than 7 millimeter. The progesterone was initiated. And if it is less than 7 millimeter, the established medication was continued for 2 to 4 days, and again it was rechecked. If it is still inadequate, the cycle was cancelled. So the FET timing was 1 or 2 cryopreserved day 3 or day 5 embryos, which was transferred on day 4 and day 6 respectively. The LPS support which was given was 25 milligram of aqueous progesterone once daily, along with it 40 milligram of oral progesterone diffesterone daily. And the HRT was continued till 10 to 12 weeks of gestation, if positive. The beta HCG value was checked 14 days after the transfer. The ultrasound was given 2 weeks after the beta HCG report. So the outcomes which was measured was a primary outcome was biochemical pregnancy rate and the clinical pregnancy rate per cycle transfer. The secondary was ongoing pregnancy and the miscarriage rates and number of hospital visits and the impact of length of the follicular phase in natural cycle on the reproductive outcome. So the table 1 shows the comparison of the age among the study participants. The group 1 and group 2, it shows the most of the participants were around 26 to 30 years of age. And the indication for ICSI was group 1 and group 2 was more of female factor, of group 1 having 10 and group 2 having 17. The distribution of day of embryos among the participants in the natural cycle and the HRT therapy is shown by this graph. And the distribution of gametes was self-gametes were more common in both the groups. And the comparison of number of embryos, it was 2 embryos transferred in both the groups, which was more 23 and 26 respectively. The comparison of biochemical pregnancy rates, beta HCG positivity in the natural cycle was 50% when compared to 53% in HRT group. And the first scan, which was done in 5 to 6 weeks, it was 64.3% in natural cycle and 68.8% in HRT group. The ongoing pregnancy at 12 weeks was 57.2% in natural cycle and 43.8% in the HRT group. Whereas the miscarriage rate, in group 1, there was no miscarriage rate when compared to group 2, which had 4. So the number of clinical visits among the study participants, the group 1, which had a natural cycle, had more than 3 visits of 10 and 7 and 9, whereas group 2, which had an HRT, had only 2 visits of 28 participants and more than 3 of 2 participants. So the number of ultrasounds performed was also more in the natural cycle group and compared to the HRT group. On the day of the trigger among the natural cycle group, the participants had a trigger day from day 11 to day 15 of 14 participants. Less than 11 was 9 and more than 15 was 7. Whereas the beta HCG positive was more with trigger day between day 11 and day 15. So this is my summarized outcome. The natural cycle number of biochemical pregnancies was 15 and the clinical pregnancy rate was around 9 with ongoing pregnancy of 9 and biochemical loss of 6. So miscarriage rate was 0 when compared to HRT having 16 biochemical pregnancies, out of which clinical pregnancy was 11, ongoing was 7 with biochemical loss of 5 and miscarriage rate of 4. So my conclusion is that the present study demonstrates there is no difference in implantation rate, but with a lower miscarriage rate between the natural cycle and the HRT based cycle. So natural cycle is a safe and preferable and cost effective protocol for FET, and success rates of a natural and HRT cycle suggest that if the patient has a regular menstrual cycle, then they should be offered a natural cycle embryo transfer, which avoids multiple medications. And it allows a freedom to individualize the patient's treatment protocol.
That was a nice presentation, Abhinaya. Dr. Kavita, would you like to go first? Or Dr. Kavita is the other judge. I'm Dr. Ruma Abhinaya.
Yes, ma'am.
We will be discussing your paper. So, see, first of all, I'm very happy that you're presenting a prospective study because for conferences, not many people will be able to present their findings, which has been done over a long period of time. So that is good. The other thing is that my question to you largely is, can you derive definite conclusions from a study such as yours? And what do you think are the shortcomings? I want you to answer them before we comment.
Ma'am, it's like this study was conducted during this COVID period, so I could collect only 30 patients for my study of natural cycle when compared to the HRT. Yeah. And now I'm extending this study to the live birth rate, and I'm even including a few more patients.
Right. So what number, according to you, would have been adequate? So in infertility trials or infertility studies, even if they are cohort studies, if you have to make a conclusion, what numbers are usually adequate?
Ma'am, more than 100 or more than that.
So we usually expect, let's say we are suggesting that natural cycle is better than HRT, and we estimate the difference to be 10%. Usually it will not be more than 10%. Then the numbers we're looking at is 600 to 700. That's the numbers we're looking at divided into. Okay, that's one. So one is sample size, and I understand your limitation that it was COVID. However, I appreciate the fact that you've presented this study. It's a prospective study. Second is somewhere you said randomized, right?
Yes, ma'am.
And then you said at some point computer generated, and then again you said alternately assigned. Which of these is true?
Ma'am, we actually alternatively assigned. Is
that the right method for randomization?
It's 1:1 ratio, ma'am. It's computer designed. It's not alternate.
Yeah. So alternate. What limitations can alternate allocation have over computer generated allocation?
Ma'am, like a subjective bias, like we design, we give it.
Very good. So selection bias can come in. Okay. So one more thing is, so your PICO, if I were to ask you what your PICO is, would you be able to answer it? What is your population? What is your intervention? What is the comparator? And what is the outcome you're studying?
Ma'am, my population was IVF embryo transfer couples,
Yes.
and my outcome was.
There is something more. Population, you had specified, it was very specific based on your inclusion-exclusion criteria. Now, my problem with that population was that you included donor egg gamete as well, along with regular, and then you, of course, decided that both groups are probably equal. But usually donor egg population or third-party donation, usually they'll constitute a different group. We try and not mix those two populations together, okay? Because donor eggs are likely to be younger, they're likely to be belonging to women who are not fertile, are not infertile. So their outcomes can be very different. And then in small groups, when you have small intervention groups, small comparator groups, it is very difficult to control for these variables, right? Even if there is a 10-15% difference, your p-value will come as insignificant, although that might matter. So that is it, but I congratulate you on your studies.
Yes, thank you.
Thank you, Dr. Abhinaya. Moving on to the next participant, we have Dr. Ankita Sethi presenting on, does COVID-19 vaccination affect the outcome in vitro fertilization? Dr. Ankita, please share your presentation.
I've shared my screen.
We can't see your slides. Your slides are not visible.
Ma'am, we can see
have
your
shared my
screen now.
screen.
Just open the presentation.
Okay.
Yes. Make it slideshow.
May I start now?
Yes, ma'am.
Good afternoon, everyone. I am Dr. Ankita Sethi. I'm a DM Reproductive Medicine resident in Department of Obstetrics and Gynecology, AIIMS, New Delhi. I'll be presenting on does COVID-19 vaccine. As you all know,
Dr. Ankita, your connection is very unstable.
consists of three
Dr. Ankita, the transmission is lost.
Okay.
Dr. Ankita, in the
Should
meanwhile,
I
just go to the third
yeah.
participant. Please move to an area which has better connectivity, because like this, you'll not be able to present flawlessly.
Okay.
I invite Dr. Anviti Saraf to present on effect of dual trigger versus HCG trigger on ART outcomes in poor ovarian responders, stratified according to novel Poseidon criteria, a prospective observational pilot study.
Good afternoon, everyone. Is my slide visible?
Yes, ma'am. We can see your slides.
Good afternoon, everyone. Effect of my study is on effect of dual trigger versus HCG trigger on ART outcomes in poor ovarian responders, classified according to Poseidon criteria, a prospective observational
observational study. Failure to respond adequately to controlled ovarian stimulation is termed as poor ovarian response. Despite adequate scientific advances, there is still no consensus on the standard management in these group of women. It is a known finding that there is a strong association between the number of oocytes retrieved and the live birth rate. One of the strategies to improve the number of oocytes retrieved is using dual trigger in place of traditionally used HCG trigger. The GnRH agonist component in the dual trigger works by the initial flare-up effect, causing not only LH surge, but also FSH surge, which mimics the natural cycle more closely than HCG. Advantage of having an FSH surge is that it stimulates deposition of hyaluronic acid by the COC, responsible for cumulus expansion, upregulation of LH receptors on the granular cells, and cytoplasmic maturation, which helps in improving the mature oocyte yield. However, GnRH agonist alone results in early uterolysis because of its short half-life, and its response is dependent on the optimal levels of LH on the day of trigger. So combining HCG to GnRH agonist, thereby making it a dual trigger, has the beneficial effects of agonist while overcoming its shortcomings. So based on this mechanism of dual trigger, using it in poor ovarian responders seems to be a better alternative to HCG trigger. However, the data regarding the use of dual trigger in POR women is still lacking, and most of the studies have used Bologna criteria to define POR. So according to the new Poseidon criteria, it divides POR women in 4 groups based on their age, ovarian reserve, and ovarian response in previous stimulation, which makes the comparison more appropriate between the groups. The aim of my study was to compare the number of mature oocytes obtained following dual trigger versus HCG trigger in poor ovarian responders. Primary outcome was the total number of M2 oocytes. Secondary outcome were the total number of oocytes retrieved, fertilization rate, top quality embryos on day 2, day 3, and day 5. It was a prospective observational pilot study conducted at Milan Hospital, Bangalore between April 2020 to November 2021. Inclusion criteria: all women with who are poor ovarian responders defined as per the Poseidon criteria undergoing stimulation with antagonist protocol were included in this study and categorized into 4 subgroups. So POS1 and POS2 are women with a normal ovarian reserve but with a poor or suboptimal response in the previous ovarian stimulation, and POS3 and POS4 are the women with poor ovarian reserve. Age group between 20 to 40 years, BMI between 18 to 26, and baseline FSH of less than 15 were included, while patients with hypo and male factor were excluded. Ovarian stimulation was started on day 2 or day 3 of the cycle with HMG. Dose was decided by the clinician as per the age, ovarian reserve, and BMI. Monitoring of follicular growth was done by TVS and hormonal test after 3 to 4 days of injection. An antagonist was started after, when the criteria was met. Further follow-up visits were done according to the follicular response, and dose of gonadotropin was changed accordingly. If there was no response or absent response, those cycles were cancelled and excluded from the study. When the lead follicles had reached more than 17 mm, then the trigger was given. In group A, dual trigger, that is 0.2 mg triptorelin plus 500 microgram HCG, while in group B, 500 microgram of HCG was given. Ovum pickup was done after 34 to 35 hours. Number of oocytes, mature oocytes were noted, and the fertilization rate and top quality embryos were also noted. The data was represented in the following manner. These are the 4 groups according to the Poseidon classification, and they were further divided into group A and group B on the basis of the trigger administered. Coming to the results, the baseline characteristics like the age, BMI, AFC, AMH, baseline FSH, LH, and the type of infertility, duration of infertility, and indication of IVF was comparable between the group A and group B in all the 4 Poseidon groups. Stimulation cycle characteristics like the starting dose of gonadotropin, total dose of gonadotropin, and the duration of stimulation was also comparable between group A and group B. The peak E2, LH, and P4 values on the day of trigger were comparable in group A and group B in all 4 Poseidon groups, and also here LH values were optimal for the agonist trigger to work in all the groups. Coming to the outcomes, so the primary outcome was number of mature oocytes. The number of mature oocytes was significantly higher in after dual trigger in Poseidon 1 group with a p-value of 0.046. It was also the number of mature oocytes were higher with dual trigger in POS2 group, but the p-value was statistically insignificant. While in POS3 and POS4, the results were comparable. Comparing with other studies, so other studies were based on Bologna criteria. So here only 2 studies had a significant result in which with dual trigger there was significantly more number of mature oocytes. There were 2 studies which used Poseidon criteria, but only on one class. So in one study, Poseidon 3 was class 3 was studied, and in which there was a significantly higher number of mature oocyte with dual trigger. While in one more study with POS4 group, there was a higher oocyte value in dual trigger group. Coming to the secondary outcomes, so we noted comparable result in fertilization rate and top quality embryo in both dual trigger and HCG group. So our findings were in coherence with Zhang et al. While Chern et al. And Megat et al. They found higher fertilization rate and top quality embryo with dual trigger. The strength of our study was that it was the first study to classify poor ovarian responders in all 4 groups according to the Poseidon criteria, which makes the group more homogeneous and better for comparison. However, it was a cohort study, not a RCT, and the sample size in individual Poseidon group was small, and the primary outcome was the number of mature oocytes, and pregnancy rate could not be found. Conclusion, the results demonstrate significantly higher number of mature oocytes following use of dual trigger in Poseidon group 1. Though similar effects of improved oocyte maturation were not seen in other Poseidon groups, it could be because of the smaller sample size in those groups. Further, we recommend further RCTs with larger sample size in each Poseidon group to validate the effect of dual trigger and generate individualized treatment plans.
Dr. Kavita, would you like to go first?
Yeah, so congratulations, Dr. Anviti. I think you have presented very well. In fact, you have already said that limitation, that it was not a randomized trial. So do you have any idea how actually you choose the sample size when you're going for a study so that you can have actually a good reliable results?
It was a observational pilot study. Minimum of 15 participants in each group. Like in Poseidon 1 group with dual trigger and with HCG trigger, 15 in each group should have been there. But in my study in Poseidon group 2 and Poseidon group 4, I did not I get a total of 15 in with dual trigger.
Okay.
Over to you, Dr. Uma, you can continue.
Thank you. Thank you, Anvita. Anvita, right? So a good study again, I think, on a much needed topic. We keep looking at which groups are good for dual trigger. And we do, as a general rule, know that it might work in women who have responded poorly. And I think just a general, if I were to ask you, what is the biological plausibility? Would you be able to explain us your results? Why did it help in 1 and 2 and not so much in 3 and 4? And I agree with those results in a way because of what the sense that we have. Why should it work in 1 and 2 and not so much in 3 and 4? Can you explain that?
Ma'am, in 1 and 2, they are already, they have a better prognosis than 3 and 4 because they have a normal ovarian reserve. But it should have worked in all the 4 groups. But since I had a smaller sample size in all like POS 3, 4 and 2, 3 and 4, and in POS 1 I had an adequate sample size. So that may be the reason why I got a significant result in POS 1 group.
All right. So basically, although time is up, I'm just going to end this here by just one comment. So what you're looking at is a hypo response or a poor response in women who were expected to respond well in the previous cycle. Okay, those are the ones in whom this has worked well. So if you're aware of the concept of FOI, where actually the antral follicle count was good, but the numbers retrieved were lower, it could have been because of a poorer stimulation, less GN dose, gonadotropin dose, or because, either the pituitary was too suppressed for a reaction to GnRH agonist, if at all that was given, or somehow the HCG was not enough because somehow it also needs an FSH stimulus to cause a final maturity and for the oocytes to be retrieved. However, in the other group where there is a lesser AFC, 3 and 4, right? Those are actually poor ovarian reserve. We don't expect a very huge response in that sense. So I agree with the results in a sense that, yes, it should have worked in 1 and 2 much more than in 3 and 4. And it's important to identify that in order to be able to give the right treatment to the right people. So thank you, Anvita. Let's have this was presentation 9, right? Code 9, right?
Yes, ma'am.
Yeah, okay, right.
So next we have Dr. Vahini presenting on correlation between total gonadotropin dose and oocyte quality. That's 68 number. Dr. Vahini?
Yes, ma'am. Can you hear me now?
Yes, please share your screen.
The slides seen, ma'am?
Yes, they're visible. Please put it to slideshow mode.
No, it is in slideshow mode only.
Stop share and reshare again.
Okay.
Yes, we can see it now. Click on the screen and yeah.
Good afternoon, everyone. This is Dr. Vahini, and I'll be presenting my research topic on the correlation between total gonadotropin dose and oocyte quality. Communication between the oocyte and granulocyte cells is bidirectional, and this is essential for both follicular differentiation and the production of an oocyte competent to undergo fertilization and embryogenesis. This is controlled by the gonadotrophins and the oocyte itself. The main aim of controlled ovarian hyperstimulation is to obtain multiple follicles, but the success of IVF is dependent on both the size and quality of the oocyte cohort. Aim of the study was to evaluate the correlation between total gonadotropin dose and oocyte quality in ICSI cycles in normal responders. This was a retrospective observational study done over a period of 1 year in our institute, Women's Center by Motherhood, Coimbatore. Study population, totally 50 patients were included in the study. They were aged between 20 to 40 years with regular ovulatory cycles, AMH values between 1.5 and 4.5, antral follicle counts between 8 and 23, and all the patients underwent protocol of stimulation. Patients who underwent previous ovarian surgeries, endometriosis, PCOS, and other stimulation protocols were excluded from the study. The stimulation protocol used gonadotrophins, both recombinant FSH and highly purified HMG were used. Based on the age, AMH, AFC, FSH, and BMI, the starting dose of gonadotropin was decided. The ovarian response was monitored by serial transvaginal sonography, and the dose of gonadotrophins was altered according to the follicular growth. GnRH antagonist was added on day 5 or 6 when the lead follicle size was 11 to 12 millimeters and or the estradiol levels more than 400 picograms per ml. Trigger was given with Leuprate or HCG or dual trigger when more than or equal to 3 follicles reached more than or equal to 17 millimeter size, and oocyte retrieval was done at 36 hours post trigger. Oocyte quality was assessed. After 4 hours of oocyte retrieval, the oocytes were denuded of their surrounding cumulus by using hyaluronidase. Nuclear maturity was assessed, whether germinal vesicle, metaphase 1 or metaphase 2 oocytes, and the morphology of cytoplasm and extracytoplasmic structures, namely polar body and perivitrin space, were assessed. The oocytes were graded into 3 groups according to the number of abnormalities. Grade 1 oocyte without any abnormality, grade 2 oocytes with 1 abnormality, and grade 3 oocytes with at least 2 abnormalities. The oocyte without any abnormality showed clear cytoplasm with uniform texture, homogeneous fine granularity, round zona pellucida, small PVS, containing a single unfragmented first polar body, as shown in this picture. Oocytes with extracytoplasmic abnormalities had rough or fragmented first polar body and large fragmented perivitrin space. Cytoplasmic abnormalities included dark granular cytoplasm, refractal bodies, smooth anaplasmic reticulum clusters, or vacuoles. Based on the total gonadotropin dose required, the patients were categorized into 3 groups. That is less than 1,500 international units. There were 10 patients in this group. Between 1,500 and 3,000 international units, there were 33 patients in this group. And more than 3,000 international units, 7 patients were in this group. Results based on age, it was seen that 50% of the patient population, that is 25 patients, belonged to the age group 26 and 30 years. And but there was no statistical significant difference between the 3 groups with the total dose of gonadotropin that was required. Based on BMI, it was seen that 17 patients had BMI between 25 and 29.9. Again, there was no statistically significant difference between the 3 groups. Day 3 FSH levels ranged from 1.28 to 11.9. Again, the patients were categorized into 3 groups, less than 5, 5 to 10, and more than 10. Majority of the patients had FSH levels between 5 to 10, but again, there was no statistically significant difference with the total dose of gonadotropins that was required. The starting dose of gonadotropins, 14 patients were given a starting dose of 150, 9 patients received 175, and 6 patients 200, again 6 patients 225. Highest dose of 375 was given to 1 patient. Total number of days of stimulation extended from 8 to 12 days, with 32% of the patient population requiring 10 days of stimulation. Estradiol levels on the triggered day was noted. 19 patients had estradiol levels between 2001 to 3000. 17 patients had it between 1000 to 2000. 2 patients had estradiol levels more than 4000. Dual trigger was used in 31 patients. 14 patients had loop-right trigger and 5 patients had HCG trigger. Based on the oocytes retrieved, it was found that 30 patients, that is 60% of the patient population, had 10 to 20 oocytes retrieved, and there was a statistically significant difference between the 3 groups noted. 23 patients who received a dose between 1,500 to 3,000, and 5 patients received less than 1,500 international units, and 2 patients received more than 3,000 international units. Nuclear maturity was assessed in that there was a statistically significant difference between the 3 groups in the number of immature oocytes. It was seen that majority of the patients had a less number of immature oocytes, that is 0 to 5, 64% of the patient population, and they had received a dose between 1,500 to 3,000. With the M2 oocyte, there was no statistically significant difference. When the oocyte quality was assessed in terms of morphology, with the cytoplasmic appearance, there was a difference between the 3 groups, with the maximum number of patients, 26 patients, who received 1,500 to 3,000 international units. With respect to polar body appearance and perivitrin space, there was no significant difference between the 3 groups. Again, when the oocytes were graded according to the morphology, grade 1 oocytes were seen in 40% of the study population, and they had received 1,500 units, and more than 3,000 international units. There were no grade 1 oocytes that was seen. In my conclusion, the total dose of gonadotropins between 1,500 to 3,000 national unit group showed increased number of oocytes retrieved, but less number of immature oocytes, and increased number of grade 1 oocytes. And in the group that received dose more than 3,000 international units, they had decreased number of oocytes retrieved and oocytes with abnormal cytoplasmic appearance and no grade 1 oocyte. No difference was noted in the number of mature oocytes and appearance of polar body and perivitrin space in terms of morphology. Thank you.
This is Dr. Vahini, right? Yeah, Dr. Vahini, okay, once again, congratulations for your paper. I'll be very quick. There are two things. The first and most important thing is your outcome measure is oocyte grading, right? Done by an embryologist, okay? Whenever we are studying, let's say the intention was to study what is the effect of dose of gonadotropins on oocyte quality, what should have been the ideal endpoint? What is the marker for oocyte quality? Even if you can't study live birth, even if you can't study clinical pregnancies, they should have been, so, you know, the world has moved on to outcomes which are relevant to patients, which will make a difference, because oocyte quality grading is a very subjective marker. Okay, if one has to look at what is the right outcome, even in a study such as yours, at least it could have been total top quality embryos obtained, or it could have been maybe at least a clinical pregnancy. That is one. The other is when you present your results, a single table where you define age and all the other characteristics of the population. And so that is table 1, basically to define whether the two groups were majorly different. Instead of individually presenting them in graphs, that's just a suggestion if you plan to publish this. And could you also tell us your results, which are saying that more than 3,000 is when your oocyte quality was affected, and between 1,500 and 3,000 oocyte quality, say it's not affected, or raising the dose will give you better oocytes? What was your result?
With regards to the mature oocytes, there was no difference between the two groups. Right. At the end, it is the number of mature oocytes that matter to us when they undergo fertilization.
Okay. All right. All right. So maybe you should be able to explain those results in discussion, right? Okay, I'm done. Dr. Kavita, would you like to ask any questions?
I think time is up. We can move to the next participant.
The next. Yeah.
So, thank you, Dr. Vaini. We have with us next Dr. Ankita Sethi. She's ready with the presentation now. Does COVID-19 vaccination affect the outcome in vitro fertilization? Dr. Ankita.
May I start?
Yes.
Yeah. Good afternoon, everyone. I'm Dr. Ankita Sethi. I'm a DM Reproductive Medicine resident in Department of Obs and Gynae AIMS. I will be presenting on the topic of does COVID-19 vaccination affect the outcome of in vitro fertilization? As you all know, coronavirus is a single-stranded RNA virus, and there are 4 types of coronaviruses: alpha, beta, gamma, and delta. The COVID-19 virus is a beta coronavirus, and it consists of 3 structural proteins: spike, membrane, and envelope protein. And the ACE2 receptor is a functional receptor on the alveolar epithelial cell, which is the entry point of the COVID-19 virus. And the spike protein has strong affinity for the ACE2 receptor. The COVID-19 needs TMPRSS2 also necessary for the infection to occur. And the ACE2 expression is found in heart, ileum, kidney, bladder, respiratory tract, and testes. So all tissues with more than 1% expression of ACE2 receptor could be a target for COVID-19 infection. And ACE2 is a key component of the renin-angiotensin system, modulating cleavage of angiotensin 2. And angiotensin 2 regulates the basic function of male and female reproductive systems. In female, folliculogenesis, steroidogenesis, oocyte maturation, ovulation, and endometrial regeneration. And in males, the testicular function and the sperm function, and therefore the sperm's contribution to embryo quality. So ACE2 receptors are much more abundant in male reproductive system than the female, and therefore testes are more vulnerable than ovaries to the detrimental effect of infection. There has been seen that low expression of ACE2 was demonstrated in fallopian tubes, ovary, vagina, cervix, and endometrium as well. So, like after WHO declared COVID-19 a global pandemic in mid-March 2020, all society recommended suspension of new fertility treatments to avoid complication from ART or ART pregnancies, to avoid any potential COVID-19 complications during pregnancy, to mitigate potential but unknown risk of vertical transmission, to support necessary reallocation of healthcare resources, and to observe recommendation for social distancing. But now, majority of the ART centers have restarted IVF cycles and are providing IVF cycles to patients with either previously infected or are now vaccinated with either 1 or 2 doses of COVID-19 vaccine, which could be Covaxin or Covishield. But there is paucity of literature and evidence on the impact of COVID-19 vaccination on IVF outcomes. There is just one study in literature so far which has studied the effect of mRNA vaccine on subsequent IVF outcome in Israel, which found no effect of vaccine on IVF outcome. So no study has been conducted so far to analyze the vaccine effect in Indian population, and we aim to assess the impact of vaccine on IVF outcome. So the types of COVID vaccine that are there is the mRNA vaccine, inactivated coronavirus, that is Covaxin, viral vector, AstraZeneca or Covishield, and the recombinant antigen proteins. WHO has approved these COVID-19 vaccines for emergency use, which includes Moderna, Janssen, Pfizer, AstraZeneca, Covishield, Covaxin, Sinopharm, and Sinovac. Covishield and Covaxin are the main vaccine that we've been using in the Indian population. So we conducted an observational cohort study on all infertility patients undergoing IVF cycles from July to October 2021 who had received at least 1 dose of vaccine, and IVF cycle was started at least 2 weeks after receiving the vaccine. 40 couples were included in the vaccinated group. They had received either 1 or 2 doses of COVID-19 vaccine, either Covaxin or Covishield. The control group was matched with the vaccinated group on the basis of age, BMI, AFC, and included 60 couples who underwent IVF ICSI cycles in 2019 before the COVID-19 pandemic. The clinic's strict policy is to screen all patients using a nasopharyngeal swab for COVID-19 before starting the ovarian stimulation, and all couples with COVID-19 are RT-PCR negative before start of ovarian stimulation or pickup. So as I said, that the control group was the ones who underwent IVF in 2019. 60 couples were included, and they were matched on the basis of age, BMI, AFC, FSH, and LH. As we can see, the p-value is more than 0.05. So this table compares the stimulation cycle characteristics in the vaccinated and the control group. As we can see, the total dose of gonadotropin required was significantly higher in the vaccinated group, and there was significant vaccinated group had significantly less number of oocyte retrieved, grade 1 oocyte and grade 1 embryos, and the clinical pregnancy rate was also significantly reduced, like 10% in the vaccinated group as compared to 30%. After adjusting age, BMI, AFC, FSH, and LH by logistic regression analysis, the odds ratio of clinical pregnancy rate was 0.26, which was again statistically significantly reduced in the vaccinated group. So there's been only just 2-3 studies on this aspect. One is ovarian follicular function is not altered by either COVID infection or vaccination. This was published in August 2021 in Human Reproduction, in which basically they saw whether the immune response to either COVID-19 infection or vaccine involves the ovarian follicle and does it affect its function or not. They included 9 patients who had confirmed infection, 9 who were vaccinated, and 9 were the controls. And they found no difference between the 3 groups in terms of the ovarian follicle quality. They saw the potential effect of either infection or vaccination of ovarian function. They did assessment of the follicular steroidogenesis, showed similar normal rates of E2P for production. The assessment of response of follicles to the trigger also showed normal or similar response in all the 3 groups. They also found that there was rapid production of COVID-19 antibodies that were detected in follicular fluid of the patient. But they saw that this immune response did not lead to any measurable detrimental effect on function of ovarian follicle. Another group by Orvieto et al. Published in 2021 whether COVID-19 infection affects the IVF outcome or not. They included 9 couples, out of which 7 female partner had infection and 2 male partner had infection. And they found not significant difference between the 2 groups, except that there was reduced proportion of top quality embryos in the vaccine in the patients who had history of infection. So they suggested to postpone IVF treatment for at least 3 months, which is actually the duration of the folliculogenesis spermatogenesis after recovering from COVID-19 infection. This study by the same group, they saw whether the mRNA vaccine influences the patient performance or not during IVF cycle. They included 36 couples and they did not find any difference in the patient performance of ovarian reserve in the immediate subsequent IVF cycles. So, but they suggested that since folliculogenesis and spermatogenesis are complex dynamic processes involving multiple endocrine cells and numerous signals, then they have estimated span of 3 months. So, COVID-19 infection, by its known ability to activate release of large amount of pro-inflammatory cytokines and precipitate and sustain an aberrant systemic inflammation, which can result in low-quality embryos. But lesser degree of systemic inflammation induced by vaccine may or may not affect the folliculogenesis or spermatogenesis. But our limitation was that it was a small sample size, and we included patients from both Covaxin and Covishield, and whether they received one or both doses of vaccine. So I would like to conclude that the influence of COVID-19 on female and male reproductive system needs further investigation. Currently unknown whether COVID-19 could induce a chronic systemic inflammatory effect which may impair the ovarian reserve. Immediate need for more research on ART during COVID-19 pandemic to address the open question on impact of virus on reproduction, to allow for more informed patient care and counseling. And looking at our result and our observation, we suggest that vaccine may affect patients' ovarian response or clinical outcome in their immediate subsequent IVF cycles, and any potential inflammatory environment following the vaccine may interfere with the intricate complex processes of folliculogenesis spermatogenesis. This also raises the question whether we should wait for a specific time period before starting IVF cycle post-vaccination so that the
times
are not affected. Thank you.
Yeah. Dr. Ankita, I have just 2 comments to make. I think your study idea was novel. It has to be studied. We agree with you. My 2 comments on your presentation are that in your discussion and introduction, you are conflating infection effects on fertility with vaccination effects on infertility. Suggestion is to stick to the title of the presentation, which remains, how does vaccination affect outcomes? That's one. Second is, I think I'll stop here. Dr. Kavita?
Yeah, I would just like to ask you, do you think your results were due to the difference in the vaccination, that they were not vaccinated or vaccinated by one dose? Or do you think the results were maybe they had a previous infection, previous COVID infection, and that is why your results came out to be different? Do you think vaccination is really affecting, or you think it's the past COVID infection which has led to these results?
Patients who had received vaccine only and they were not previously infected. So they had received either 1 or 2 doses of vaccine, either Covaxin or Covishield. And we recruited patients after 2 weeks of vaccination, which is majority of the recommendations by majority of these societies. So the question that we wanted to answer was whether it is affecting or not, because that has been seen in the last 3-4 months. We were seeing that our results are not coming very good. So whether vaccine has affected it or not. And the second, when we read the discussion articles, then we found that maybe we should wait for 3 months before starting IVF cycles in the vaccinated patients, because that is the time for the folliculogenesis and spermatogenesis to the second cycle to come up, so that a better ovarian response and a better oocyte and embryo quality we can get. And actually significant difference was there between the non-vaccinated group and the vaccinated group, because in the 2019 was a control group. In that time, COVID-19 was not there, neither vaccination nor the infection. So we had matched both the control and the vaccinated group, and significant result we could see. The difference was there. So I would just suggest that maybe a time gap should be there.
You could have looked at women who did not receive even a single vaccination. Did you take any patients for IVF in these past 5 months who did not receive even a single vaccination?
No, ma'am, we will take patients who are vaccinated, at least with
You
one.
have not started any IVF cycles in unvaccinated patients. Is that what you're saying?
Taking only vaccinated patients.
So no cycles have been started at your center in unvaccinated individuals?
Ma'am, at least 1 dose of vaccine all our patients have received.
Okay. Okay.
Thank you, Dr. Ankita. I would now request Dr. Harsh Patel to present on fetal-maternal outcomes and hypertensive disorders of pregnancy in tertiary care hospital. Over to you, Dr. Harsh. Dr. Harsh, can you hear me?
Dr. Redem, we had only these 4 in our list. We don't have this 5th one in the list.
This was added yesterday, and
Achha,
that's the
okay.
last one that
So
we
we'll be
have.
adding it separately and giving them.
So the serial number is 49, Dr. Harsh Patel. Dr. Harsh, can you hear us? Please unmute yourself and start the presentation. So Dr. Harsh, that was me, please. I was just trying to connect you telephonically. Can you please start?
Okay, please.
Please don't call me back. I was calling you up so that you can start your presentation. Dr. Harsh, you were sharing the screen earlier, but I can't see your presentation now.
It's not working.
Any technical issues in sharing the presentation? Earlier we could see your presentation.
Yes, ma'am, it is not.
Himanshu?
Yes, ma'am. Start sharing your screen. What?
The button is not working.
The button is not working. Share screen button.
Ma'am, you have to rejoin the meeting.
Okay, I have to leave this.
This is a non-IVF paper in this session.
Yes, ma'am.
Are there awards being given as per category or how?
There was no category as such that I have received. The markings is also not related to that fact. And since this was a last minute addition, not much.
All right.
But we are running short of time. It's going to be too.
He has joined, I think. Harsh has joined, so you can invite him again.
Dr. Harsh, are you able to share now?
No, actually, that share screen button is not working.
Not working, like you are clicking on it and it's not up.
I'm clicking on it and it is not functioning after that.
Okay. Do you have any other device to log in?
I think you can mail your slides to the technical team and they can run the slides. If that is the issue.
Yeah, I can do that. I'm mailing my slides to the technical teams, ma'am.
What we can do is, Dr. Harsh, I would request you to present it tomorrow then.
Yes, ma'am. It will
Because
be.
this will take some time. We'll adjust you in a slot and inform you about what the slot is. Is that okay?
Okay, ma'am. No issues. I will present it tomorrow.
Thank you so much. And really sorry for the inconvenience. And we'll do a trial before you actually go live.
Yeah, okay, ma'am. Thank you.
So, thank you, judges. Thank you, Dr. Kavita, Dr. Uma, for judging this session of oral presentation. Thank you all the participants for presenting your research work. It was great and it was very enlightening. Thank you so much. From here on, we move on to our...
Thank you, Dr. Rhythm and the whole organizers team of Fertivision for making us a part of it. We really enjoyed. The presentations were really too good.
So from here on, we would move on to our next session, session B1. And to chair the session, I would like to invite Dr. Ruma Satvik. She's consultant, Center of IVF and Human Reproduction. Ma'am, please stay with us for the next session too. Dr. Shweta Gupta, she's consultant in Fertility and IVF, Akanksha IVF Center and GenX Clinic. Dr. Natasha Gupta, she's consultant Indra IVF, Chandigarh. I welcome you all for this session.
Good afternoon, everyone. We would like to start this session by welcoming Dr. Reema Dada, Associate Professor, Lab for Molecular Reproduction and Genetics, Department of Anatomy, AIIMS, New Delhi, to speak on an important yet forgotten topic, men and miscarriage. I welcome you, ma'am. Do we have Dr. Reema with us?
Ma'am, no, ma'am. She has not joined yet.
Okay.
Ma'am, we can move on to the Dr. Yadava. Yeah.
So I have the pleasure of inviting Dr. Yadava Jeev, who's a consultant subspecialist reproductive medicine and surgery and deputy clinical director at the Birmingham Women's Hospital. He's also the honorary senior clinical lecturer at the University of Birmingham. And Dr. Yadava is going to deliver a talk today on quality and quantity of oocytes in the reproductive outcome. We look forward to hearing from you, Dr. Yadava.
Hello, good morning from UK and good afternoon there. Thank you for inviting me, and it has always been a pleasure actually to fly there and come and speak there, but with this new circumstances, it's just we're using the same after presentation my clinic will start, which is not really a great thing, but it's lovely to speak on this topic. This is a very, very important topic in terms of the, and I will just share my screen now. Just give me a second. So this topic is mainly to discuss the role of the oocytes in terms of the qualitative and quantitative outcome of the, okay, just give me a second, screen. Quality and oocyte leading to the reproductive outcome. So there are two, basically the reproductive outcomes. One, as we know, and as we all want, is the conception. And the second outcome is obviously the negative one, either failed conception, miscarriage, implantation failure, or any failure leading to the conception. So the outcome is either yes or no. And that's why it is really important to focus on the quality and quantity of the eggs and oocyte, where most, I mean, sperms are very important, but once the sperms comes in, it's the egg which gives the energy to the early developing embryo. It is the mitochondria that gives the energy to the cell and the development of the embryo. I would like to outline my presentation with few things. How does the quality and quantity of eggs and natural decline in the fertility happens? Because unless we understand this, we wouldn't know that how quantity and quality decides the success and what we can do to improve that. Because that's the key question for all of our patients. and then the conclusion. Would like to start the presentation with the quote from Albert Einstein. I will end the presentation with again another quote from Albert Einstein. And that these quotes are really, really important in our day-to-day life. The formulation of the problem is often essential than its solution. Solution which may be merely a matter of mathematical and experimental skills. When I was trained and studied in India, which was actually a great teachers and the place to learn the medicine, we are more focused on the pathophysiology. We are more focused on finding the problem. We are more focused on understanding how things work. When I came to UK, and then we started into a new era and new world of more of guideline protocol-based type of practice, or then we started calling it evidence-based medicine practice, etc. We became more focused on the applied. So nowadays we want quick fix. We want the solution. Most of the audiences are more interested in rather than how the quality and quantity develop than how we could improve it. And again, it's not wrong because we want nowadays everything quick, like Amazon Prime generation. Our patients they come in the clinic, by they go out, they want a baby. They are not ready to wait. And so as the pressure is on us as a clinician, that we are more focused on the applied knowledge. And this is where it is essential. So if we want to make a real difference to that last 80% of time, it will work. But those 20% of patients who are really were struggling with the success, this is where it helps, the formulation of the problem. So we need to more focus on the problem. Let it be a quantity, let it be a quality, let it be the male side, let it be any aspect of the medicine, formulation of the problem, more focus on the disease pathology, pathophysiology, and what is happening is more important. Then it becomes just, as Einstein said, a simple calculation to fix that problem. So there are like a series of papers I have done, and I have just divided those papers into different aspects. So how quantity and quality is interlinked. You can't have the good quantity and bad quality and vice versa. You may have some impact on the quality when there is a good quantity and vice versa, but they are interlinked and most of the time they go hand in hand. And then that's the series of papers. So first we focused on how the AMH and age affect the quantity and how the prediction could be done. Then the another aspect, which is very close to everybody, is poor ovarian responders. Whatever you do, do short, do long, increase the dose, reduce the dose, use mixed type of gonadotropin, use the purified, use alpha isomer, use beta isomer, do whatever. But still we struggle with poor responders. Alternative solution to poor responder is donor eggs. But is the donor egg that simple? No. Again, that how itself it has some impact on the pregnancy. The outcomes are also the poor fertilization rate, and it starts from fertilization. It starts from the implantation and then the miscarriages. So these were the series of papers I did for the quantity and quality of oocytes, and these are the papers published. Again, the point here is not to mention about the papers and not to go through my papers exactly. The concept here is to discuss that how these eggs affect the quantity and the quality and how that affect the reproductive outcome. This is very famous. We all know. As age go up, the number of eggs drop down. When the female fetus is 18 to 20 weeks of gestation, that's the topmost maximum number of eggs present in the ovaries. And by the birth, it drops down from millions to a million. And at puberty, it becomes 30 to 40,000. And during the reproductive lifespan, which one may calculate, if a girl starts a period at age of 15 and finishes her period at age of 50. So imagine 35 years of reproductive life, no contraception use, no pregnancy, roughly 28 days cycle. So 35 multiplied by 12 and plus some days. So it goes to roughly 400 cycles or 400 eggs utilized in the whole lifespan of a girl. So the question here is, then what happens to other eggs? And those other eggs, either they come as a cohort, they die off. Some of them just die off before even starting. And this is the focus of all of us as a reproductive specialist, that how we make those eggs work. when patient comes to us. And that is the key actually, and the quantity and then the quality aspect of this. So age is important predictor, but for the quantity as well as quality, and this is how it drops. So exactly the same thing what I explained at 37 years, 25, 50 plus years, thousands of, again, around 50 years, there are a few eggs still left. So there are 3 types of eggs in the ovary. One is sleeping eggs, that they are absolutely inert. This is where I explained this to patients. The second type of eggs are hormonally active eggs that releases AMH, and that could be bit of hormonally responsive. And third type of eggs, which we see into the follicles as antral follicles and the different stages of the follicular development. So AMH checks the eggs which are not sleeping eggs, really, the eggs which are hormonally responsive and releasing hormone. Antral follicle count checks the eggs which we could see actually on the scan. And the FSH is always used traditionally, but we all know now it's not a very reliable marker for the number. And the focus is always those primordial or immature eggs, how we want them to awaken. And this is the real gist of treating poor responders, treating any patients, and still we don't have a solution for that. There has been different studies, different models developed, cutting the ovaries, having different things, but nothing has proven as evidence-based. Then come down to the primary follicles, and they are the awakened. They start their journey towards becoming an egg, and it takes, as you could see, that massive number of days for them to go to either ovulation or a destruction. That's the fate of their journey. The secondary follicle then goes on the journey for 290 days. And this is what all those young doctors listening to this conference, I would like to emphasize that please focus more on the physiology. Focus on what happens in the body. Focus on the reproductive endocrinology and reproductive physiology. Then it's just so easy. You don't need to follow the protocol. You don't need to follow that what the world's renowned clinics are doing and what they're using short, they're using long. Just don't copy and paste, because every patient is different. We do not want to create McDonald's. We want to have a fine, posh Italian restaurant where we cater our patients with the recipe what they need, rather than catering the same recipe to everyone. And that is the key actually to make the difference in the success. So the physiology I was explaining here is primordial follicle, primary follicle, secondary follicle, and then the antral follicle. Now, when the patients ask you about the dose, why I want 3 months of supplementation, why I want change in the lifestyle, why I want change in the diet, and how long it takes, this is the answer to that. As I said you earlier, that and here famously I say the patients, and in all UK conferences, that patients want Amazon Prime babies, they want delivery next day. But this is where we want to emphasize on how much it takes. And I will come to the quality, and then I will give you one analogy. So the quality of the eggs, as you could see, whenever we discuss the quality, it is very defined to define a quality. Difficult to define a quality in any aspect of the life. If you want to judge the quality of my presentation, it is difficult, because you have to compare with something else. Again, there is no standards. So the quality actually is when the egg is put to the real test. That means when it is put to the fertilization or getting a pregnancy, then in retrospect, we know that actually it was a good quality. But having said this, these is the few images that the embryologist always show you. They tell me the different descriptions. Sometimes it's very in the lay language, and you would be surprised to know. Then they say that, oh, egg looks granular, egg looks giant, egg looks this way or that way. But in exactly what it means is there might be the asynchrony between the nuclear cytoplasmic maturation. There might be some problems with the development of the cell organelles, because it's such a subtle process. There might be some problems with the structure of the eggs. SER discs, again, that's a major problem in the ICSI and IVF, and that leads to more of miscarriages, congenital anomalies, etc. So basically, this is what the quality of the egg means. Now, the relationship between eggs, age, and the egg quality, as I have shown you in this chart, again, it declines with age, because your cells are as old as you are. So two areas of egg and the synchrony of development is important for the quality, as I have shown you here, that why and what exactly that means. Now here I could give you the analogy of baking a cake, which is a very famous analogy, and I could give in the UK. Obviously, you could use an analogy of making a curry or anything really, whatever the dish you like and what your patient like. But the analogy is, okay, if I'm baking a cake and I'm a very bad baker, and truly I can't really bake any cake. I can make delicious curries, but baking a cake, if I'm not a good cook, how can I blame the ingredients? How can I say that the sugar was not right, the flour was not right, or eggs wasn't from the free range chicken, or they were not right? No, I can't. Basically, it's also that how I turn the heat on, how I mix the ingredients, and how the end product is delivered. Most of the time in our medical life, in our student life, we are taught to put a blame, and this is general in life, to someone else, circumstances, government, hospital management, nursing team, anesthetist, and patients. We never accept that it could be what we did could have been different. And then when the consultation comes and when the patient comes and asks you why my cycle failed, it's easy. It's a lot easy to say that, you know what, there was a problem in the quality of eggs or quality of sperm or quality of embryos. And when they ask why the embryo quality was not good, then we say, oh, it could be the quality of eggs or could be the quality of sperms. But here we forget to mention that, you know what, there are three parties involved in this: male and female partner and the doctor, to create that cake, so bake that recipe. So sometimes it could be the environmental, sometimes it could be the protocol, sometimes it could be the lab, sometimes it could be how we did it. Now, it's obviously it's a fine line, what you explain to the patient, what you discuss to the patient, but it's a balance. You also don't want patient to take home the message that their eggs are really bad and they could never have a child, or their sperms are too bad, they couldn't have the child. And this is the balance, and this is the balance. And sometimes I give that analogy that, look, sometimes cakes doesn't turn out the way we want, and it is a mixture of many things which we really don't know, and sometimes it's better to just give the different try with different strategies. And that is important. So coming back to this reduced success to the IVF or fertility, this is the qualities problem. Quality reduces the success. It's not doesn't reduce the number and increases the miscarriage rate. So as I said you earlier and shown you how the quality goes down, exactly the similar pattern, the miscarriage rate goes up with the age. So what are the different factors in the lifestyle, apart from the age, that can affect the quality of the eggs as a baseline egg? And I'm not saying that the cooking or how we affect the protocol, etc. So going to the basic ingredients. So the oxidative stress, there are so many things in the modern life. In older life, there was less requirement of fertility doctors. When I joined Birmingham as a registrar, following my training, etc. in India and my further reproductive medicine education in UK, we had just like 3 or 4 clinics running. Now, even if we run a clinics, so many clinics every day in public and the private sector. In the UK, again, most of the fertility is not funded by the public sector, so it's all in private sector. We still are overwhelmed with the number of patients. So why is that happening? What has changed in few years' time or last 2, 3, 4 decades? It's diet, it's the diseases, it's the pollution, it's the stress with the modern working life. Previously, we used to send the letters. We were expecting the response after 7, 8, 10 days. Now it's the email, it's the messages, it's the media, and then you expect instant response. You expect instant tweets. You expect instant likes, comments, response to the emails, etc. So everybody working in everywhere, in any aspect of, and previously we used to say, oh, cooks are more risk and somebody working in this area is more risk. Nowadays, everybody is at risk because there is a very much mix of the lifestyles and the stress levels. Smoking and alcohol has always been a problem, and it will still remain a problem. And obviously now there is more awareness about that. Reactive oxygen species, nitrogen species. So as you know that all this oxidative stress can cause the damage to the cell organelles, cells energy metabolism, mechanism, and subtle changes in the cells. So that can affect the quality. Oxidative stress associated with endometriosis, hydrosalpinx, or any chronic inflammatory or hormonal condition that can also potentially affect the quality. And these are the different mechanisms or the molecular level mechanism how this ROS species or the oxidative stress can damage. Now we are talking here of the same age group patients without any medical condition, but having a different lifestyle pattern, how it can affect, or different chronic illness or inflammatory conditions can affect the quality of the eggs. And this is where then your personalized treatment comes in. So what can we do about this? There are two approaches. First approach is improve quality, aim for high quantity. So there is a statistical advantage. If I have high quantity, roughly I would get better number of high quality eggs, or focus on the quality, or aim for both. Actually, that's ideal, isn't it? So aim for reducing the oxidative stress, enough raw material for the egg development and the process, and I will just explain you how that process works. Personalizing stimulation protocols. You know, as a good doctor, you should always start thinking of the patient, how they walk, how they behave, what they see. Not necessarily what they speak is entirely the thing they want to tell you. Many things are with the body language. Many things are with the subtle communication that is not verbal communication. Many things are hidden in their history, such as what they have done, what the other medical history. Sometimes patients do think that this is not relevant to fertility, but it's leading questions you ask them, and then you try to find out, oh, hang on, this patient also suffer with certain other autoimmune conditions that could generate the autoimmunity against the ovaries. That could explain her low AMH or low egg reserve. But unless you ask, patients wouldn't tell you. Because they many times they think that if they are in gynecology or fertility clinic, they would always talk about the gynecological issues or other issues. So that is important. Then the personalizing the stimulation protocol. And this is where I come up with this P4 fertility, and that's also the brand I use in the UK. It's called, and it's based on the 4 principles: prediction, prevention, personalize, and participation. So basically, we have to predict at every stage what my patient's prediction, the chances of success, chances of failure are, how I prevent their risks, how I personalize treatment for that couple, not catering recipe like McDonald's, the same burger. And if you cater the same recipe, it really doesn't matter. This is what the chains or the other systems of the corporate world want to do, because that's cheaper. That gives them the mass production, and mass production line gives more benefit, but that really doesn't cater the need of certain category of the patient. So you could be mediocre, but you can't be excellent. And the second thing, the professional satisfaction. There is no fun than treating a complex patient.
Remind you of the time.
So thank you. So I will just come down to dietary antioxidants. So we all know that these are the dietary antioxidants, no smoking. Again, as I said, we focus more time on the problem. So the solution is always simple, that gives something that is antioxidants. Lifestyle changes, and we also mentioned in one of my slides, is medication as well as meditation. So you also always need to give some positive outlook, some reassurance to the patients, try to reduce the stress. There is no single magic answer. In UK, it is mandatory to have a counselor attached to every fertility clinic, and we are mandatory to offer the counseling to all couples. So that's why meditation, counseling support, and the group support comes in picture. But as I said you earlier, one size doesn't fit all, and you have to go with all the complex measures together and start improving the quantity and the quality of the eggs. Now, I'm not going to spend more time because the time is running up. So we all know that different substances we use to reduce the oxidative stress, and commonly used substances are, as I listed you an earlier slide. Medications, there are they work on the certain phase of the oocyte development, which I have already showed you. And this is the Cochrane. So what is the evidence shows? I mean, there is not a very, very high quality evidence to suggest that use of antioxidant helps to reduce the risk of adverse reproductive outcome. So there are some coenzyme Q10 is commonly used, DHEA is used, but evidence is not really supportive, because evidence does not go with a case selection, and that's one of the problems. So again, this is just a quick one to go through the protocols. So basically, we always have this timing, what protocols to use, when to stimulate, recombinant or natural. We already spoke many things, and we already spoke on P4 model. So the quality and the quantity is important to improve. Pre-treatment optimization is important, and that should be considered. One size doesn't fit all. Personalized treatment plans are very important. And this development is pre-cycle, because you can only cook what you got, and you have to start cooking a little bit earlier with different things. Actual IVF cycle is the actual last phase you do. And if you don't have the baseline good quality of antral follicle or the quality, you will get whatever you got. And this is the main emphasis, that you start these measures a bit early for those patients. There is no conclusive evidence of benefit or harm, and the choices should be made with antioxidants after full discussion. Protocols, we discussed that. And the last but not least slide, to raise new questions, new possibilities, and old problems with new angle require creative imagination. And that is what makes the real advances in the science. So the point here I want to make is, it is a very, very old problem. We need to look into the new angle. It requires creative imagination. It requires the thought process and imagining that how we could improve the quantity and quality of eggs to improve the reproductive outcome. And knowledge is important, but knowledge is just the quick fix. Imagination and evolving on that will make the real advances in the science and reproductive science. Thank you.
Thank you so much, sir. Next, we have Dr. Shweta. Please invite the next speaker.
Rhythm, just one quick one. Yeah, could we request the speakers to stay back for questions later?
Yes, ma'am.
Yes. I would now like to invite Dr. Reema Dada, Associate Professor, Laboratory for Molecular Reproduction and Genetics, Department of Anatomy, All India Institute of Medical Sciences, New Delhi, to speak on an important yet a forgotten topic, men and miscarriage. I welcome you all. I welcome you, ma'am, and we look forward to hearing from you. Ma'am, please unmute yourself.
Yeah, can you see my slides?
Not yet. We can hear you now, but we can't see your slides.
Okay, can you see them now?
Yes, yes, ma'am. Just full screen and then you can start.
Okay. Thank you for the introduction. And I would be talking to you about the role of men in miscarriages. And I would highlight to you that just sperms are just not mere vectors of paternal DNA, and their role extends beyond just fertilization as is believed, and they are determinants of both embryonic viability and developmental competence. And during the course of this talk, I'll take you through that whether you can actually pick out the sperm which have gross defects and what are the risks of using them, how we can screen the sperms with poor embryogenesis potential, what are the factors that cause poor embryogenesis from apparently normal sperms, and how we could use a mind-body intervention in the management of men who are in the management of couples who are having miscarriages, whether they are sporadic, I mean, if it's sporadic or recurrent. And we've been working on for the last 10 years on the male factor in recurrent implantation failure, as well as spontaneous abortions following natural or assisted conception. And since there is comorbid depression, I would also be talking on the role, as I told you, of the mind-body interventions. So as we know that human reproduction is a rather inefficient process, and 2/3 of fertilized oocytes do not produce live births, and they result in pre and post implantation losses. But though there are a large number of factors and the female factor is intensely investigated, for example, we find that there is a direct correlation with advanced maternal age with spontaneous miscarriages. We find that other factors, for example, uterine endometrial defects, immunological disorders, endocrinopathies are intensively worked upon. But the male factors are totally ignored, though they contribute half of the genome. And not only the genome, there are a number of other factors that they also transmit and maternal. And I would be talking on each of them, the effect of father's age, the different sperm defects, sperm DNA fragmentation, oxidative DNA damage, sperm aneuploidies, and epigenetic errors all contribute to an increased incidence of miscarriages, and which could be responsible for all those cases, about 50% of which are unexplained, are actually because of the male factor. So we see that at the time of fertilization, the sperm is not only transmitting the DNA, the integrity of which is very important, but it also transmits a host of these sperm transcripts, which are required for early development, as well as non-coding RNA, which are regulating the expression of several other genes. It's also transmitting various factors which are required for activation of the oocyte and centrioles. Just a brief about the sperm. It's important also to understand that since it's a transcriptionally inert cell and translationally silent, therefore majority of its genes are silent, but it has some few genes, the promoters of which lie in the periphery of the sperm nucleus, which are actually coding for genes of developmental importance. So those remain active. And the transcripts of those genes are very, very vital for the birth, for early embryonic events. In addition to that, the sperm is the only cell in the body which is not able to protect itself from the oxidative damage and various environmental factors and toxic insults, because it loses majority of its cytosolic antioxidants during spermiogenesis. So we published this paper, and as we all know that if there are infertile couples and they go in for assisted conception, they encounter frequent abortions, and usually aborters are infertile. And since there are common factors between infertility and abortion, I would just like to highlight them. We see that advanced paternal age, lifestyle factors, smoking, alcohol consumption, psychological stress, anxiety, depression, excessive exposure to radio frequency electromagnetic radiation, all results in oxidative damage, oxidative stress, which damages both the nuclear and the mitochondrial genome, resulting in shorter telomeres, which actually can impact cleavage, slow down the embryokinetics, results in the production of this base, which induces both mutations and epimutations. I'll talk about it again. And it also results in fragmentation of DNA and oxidizes the DNA. And this, because the sperm's DNA repair mechanism is inert, it's not able to clear the DNA damage. It depends upon the maternal age, and with advanced maternal age, the oocyte's repair capacity is also suboptimal. And this actually results in congenital malformations, childhood cancers, complex neuropsychiatric disorders because of de novo germline mutations in the sperm genome, and also in recurrent spontaneous abortions. So when we started this study in 2010, we saw that there were a dysregulation of a number of transcripts, which resulted in idiopathic recurrent miscarriages. This work was carried forward by Dr. Vidhu Dhawan, where we showed that paternal factors like oxidative stress, DNA damage, and also dysregulation of the transcripts actually results in can explain for a large number of cases which are still, which were classified as idiopathic with unexplained recurrent pregnancy losses. And we've also now shown that yoga and meditation can decrease the oxidative stress and the oxidative DNA damage by upregulating the expression of several genes, which are coding for antioxidants, decreasing inflammation, increasing vascularity, and also helping to increase the expression of various genes which help to maintain DNA integrity and enhance the expression of genes which help in DNA repair. And this thus helps in regulating both and improving the quality of the sperm genome and helping in re-establishment of various epigenetic marks. So there are several studies which have shown that the sperm, though it is inert, it does have genes which are very critical for early embryonic development, that advanced paternal age increases the risk of spontaneous abortions. And because the sperm works in concert with the oocyte to repair the DNA damage, it has been seen that advanced maternal age actually results in it's not able to clear the oxidative damage, and the persistence of these oxidative DNA adducts beyond the S phase actually results in these pro-mutagenic bases being found in every cell of the blastocyst in the early stages, and then it's found in every cell of the embryo's body, resulting in both mutations and epimutations. And also there are sperm aneuploidies, which have been seen to be found at a much higher rate in these in the conceptus, which is actually leading to the conceptus having higher chromosomal aneuploidies. There are other studies which have also documented in large-scale meta-analysis and systemic reviews which have shown that there is a clear-cut correlation between oxidative stress and DNA damage and the quality of the embryo. In addition to that, it was initially believed that the protamines were required just for the packaging of the sperm genome, but now it's clearly shown that in the groups with recurrent miscarriages, they are found at a much lower rate. And as you can see by the CT values, which are much higher in this group, it shows that their levels are much lower and they are required for early embryonic events as well. In addition to that, it's also important to understand that now in this landmark paper, which got published in 2019 in Human Reproduction by Aitken Group, who's really considered to be a father of modern andrology, they have clearly shown that there are a large number of loci, about 9,000 of them, which are consistently showing oxidative DNA damage in the sperm genome. And it's important to know the sperm is not able to clear it. And in this review, Robinson and his group actually showed in these forest plots that whatever may be the method for detecting DNA damage, be it sperm chromatin structure assay, be it tunnel assay, sperm chromatin disruption, you can actually dispersion, you can actually make out that high levels of sperm DNA fragmentation do correlate with recurrent spontaneous abortions, and cases with high levels of DNA fragmentation are correlated with a higher rate of miscarriages. And in addition to that, methylation errors, again, oxidative stress results in genome-wide hypomethylation, resulting in methylation errors, a decrease in the global methylation marks, which results in genome-wide instability. And I'll just show you how yoga is really able to correct all these factors. So we can see that all these factors contribute to both early and late paternal effects, which are helping in the embryonic events immediately post-fertilization. And what's important is that it's a large number of lifestyle factors which are totally modifiable, which are actually resulting in oxidative stress and DNA damage, which is like smoking, alcohol consumption, consumption of food, which is rich in trans fats, salts, and sugars, foods which have a loaded with endocrine disrupting chemicals, all lead to oxidative stress, which could either manifest as DNA oxidation, it could be double single strand breaks, or the accumulation of oxidative DNA adducts like 8-hydroxy 2-deoxyguanosine, which induces both mutations and epimutations. And since mitochondria are the source of free radicals, we've seen that they have a higher number of variations because of high free radicals they are also exposed to, and they have higher amount of free radical exposure, and also we see that they have higher levels of DNA damage. So such sperm with mitochondrial variation, high number of variations, are actually responsible for lower ATP production and thus morphological defects which manifest as oligoacinoteratozoospermia. So there is high levels of sperm DNA damage, and there are three main causes, though there are a host of factors. The most important are oxidative stress, which is usually post-testicular, post-spermiogenesis, there's testicular maturation defects, and there is abortive apoptosis due to dysfunctional mitochondria. So these are some of the studies. We find that a number of these men, about 3 to 6%, they are balanced translocation carriers, and they produce unbalanced gametes, which could actually be responsible for abortions. And it's already been seen that the early developing embryo has chromosomal instabilities common in cleavage stage embryos. We also find that a large number of these men are experiencing seminal oxidative stress, as you can see here. And we quantify them using a luminometer. And here we have also quantified the levels of DNA damage using both Comet assay. Here you can see majority of the DNA, the fluorescence is in the region of the head, showing you good quality DNA. Whereas when the DNA is fragmented, you can see long tails showing you highly fragmented DNA. And the same we have quantified using sperm chromatin structure assay using acridine orange. And you can see towards the x-axis are the sperm with the damaged DNA. And you can see the number of sperm with the damaged DNA are significantly higher than in the control cases. So we were able to actually develop cutoff levels beyond which a couple is infertile, and also levels, when the levels are below the cutoff levels for infertility, where they are able to conceive but then encounter recurrent spontaneous abortions. In addition to that, it is important that the sperms have a certain telomere length so that they are able to aid in cleavage, and very short telomeres can disrupt and slow down cleavage. Also, we quantify the levels of this oxidative DNA duct. Basically, it's to show you that the accumulation of this base is directly correlating with your lifestyle factors and social habits, and this base induces de novo germline mutations. And we've seen that this base was much higher in certain fathers of children with sporadic cancers. So they actually correlate, they result in de novo germline mutations and also result in post-zygotic mutations. So we also did this microarray analysis, and we found that a large number of these transcripts were dysregulated in both cases after spontaneous conception and assisted conception. And you can see, as compared to the controls, the levels were significantly different. So now I will tell you how you can manage these cases with high levels of oxidative stress, advanced paternal age. Can we reduce the rate at which we are aging? And then what is the impact of yoga on both meditation, yoga and meditation on both oxidative stress, DNA damage on your genome and epigenome, and how it can also impact comorbid depression. Now we have in our department, we also run a center where we have a trained yoga instructor from the Morarji Desai National Institute of Yoga. And these people are doing yoga under our supervision. And you can see that post-practice of yoga, you can see a significant decline in the free radical levels. Not only is there a decline in the free radical levels, it is also associated with a significant increase in the total antioxidant capacity, because all these people, when we look at their transcriptome, we find there's an upregulation in the expression of various genes which are coding for antioxidants. You can also see a significant decline in the level of this oxidative DNA adduct, and this is independent of any change in lifestyle. So this is the base which induces mutations and epimutations, and you can see a significant decline in the level of this base. In addition to that, post-practice of yoga, you can see that a large number of these pre-yoga levels, post-yoga levels, they are getting normalized and moving towards the levels of the normal controls. In addition to that, various genes, for example, the MTHFR, which is involved in 1-carbon metabolism, or the gene which is helping in the detection of the DNA damage, they show a positive change, and there's an increase in their expression, as you can see by their 4th chain. In addition to that, as I showed you papers which have documented that when there is oxidative stress and oxidative DNA damage, it results in methylation errors, and there is global hypomethylation, which results in unmasking of the repetitive elements, which actually results in complex chromosomal translocations, resulting in higher incidence of these chromosomal abnormalities and also genome-wide instability. And you can see that post-practice of yoga, now this was a randomized controlled trial, you can see that post-practice of yoga, there was increase in the levels of these methylation marks. Therefore, it showed that the hypomethylation which had occurred, because when there is oxidation, you find that there is the 5-methyl cytosine converts to hydroxymethyl cytosine. Those levels drop post-practice of yoga, whereas a group that did not practice yoga, you see that there is no change. And the levels, the 5-methyl cytosine marks are re-established, so you can see that the global levels increase. In addition to that, this was the first study to actually see the impact of yoga on the level of various genes which are critical for early embryonic development, and as well as for maintaining the sperm and genome integrity. We found that there were about 442 genes which were differentially methylated, and a number of genes which are helping in embryo implantation, chromatin compaction, as well as protective, which are helping to maintain the telomere length, they get hypomethylated, showing that there is an increase in the expression of genes. Now, this is very, very vital, because it actually shows that the dysregulated sperm transcript, because of damage to the genes which are lying in the sperm periphery and are the victims of oxidative stress and are susceptible to oxidative stress, are showing dysregulation. They are getting normalized. In addition to that, the sperm telomeres, which were shortening at an accelerated rate, are being maintained, because telomere length is a complex trait, and its levels actually depend upon the telomerase activity as well as on the oxidative stress levels, which target the telomeres. And we've seen that as the oxidative stress levels go down, we also find that post-practice of yoga, the telomerase activity increases, the telomere length are maintained. And this is very, very vital. Not only is the sperm telomere length being maintained, but it is also reducing the rate at which you are aging. So this is reducing your biological age as compared to your chronological age. In addition to that, when we followed up these people for about 6 months, which is the time taken for 2 spermatogenic cycles, though we know that oxidative stress we found actually showed a significant decline in just 10 days, but we find that DNA damage takes about 6 months to show a significant improvement. And you can see here that the number of sperms towards the x-axis has shown a significant decline, showing that there is an improvement in the DNA quality post-practice of yoga. And this is only possible because there is an upregulation in the expression of genes which are decreasing the oxidative stress. These are genes which are coding for the various antioxidants, and there's upregulation of genes which are helping to maintain the DNA integrity. In addition to that, the source of free radicals are mitochondria. And mitochondria are also resulting in not only producing free radicals, but as a byproduct, they are also producing ATP, and free radicals are produced as a byproduct. And when mitochondria produce more free radicals, they further damage the mitochondrial DNA. And it's been seen, though I'm giving you the example here because we started this study in an autoimmune disease that is rheumatoid arthritis. Again, this was a randomized controlled trial. We've studied this impact over various diseases. And what I just wanted to show you that oxidative stress damages not only the nuclear DNA, but it also damages the mitochondrial DNA. And the damage to the mitochondrial DNA is much more sustained and severe in the mitochondrial DNA. And thus they continue to produce more free radicals, which continues to damage the nuclear DNA. And though the sperm DNA, mitochondrial DNA is not being transmitted, but it's vital for the integrity of the nuclear genome. And so we've studied a number of genes which are actually required for mitochondrial biogenesis and maintaining mitochondrial integrity. And you can see that post-practice of yoga, in the group that practice yoga, the genes which are helping to maintain the mitochondrial integrity and helping in mitochondrial replication, they actually show a significant increase. In addition to that, we also find that NAD, which is a molecule which is helping in the crosstalk between the nuclear and the mitochondrial DNA, which goes down with aging and is one of the key factors which is responsible for aging along with oxidative stress, shows a significant upregulation. And this is the first study to show that yoga and meditation can actually improve the levels of NAD, decrease oxidative stress, and damage to both the nuclear as well as the mitochondrial genome. Now, these findings would also be very useful. Yeah, I'm just ending this. This is, I think, the last slide. And in addition to that, we also, the integrity of the mitochondrial DNA is also vital for the oocyte, because oocyte is transmitting the mitochondrial DNA, and it's been seen that suboptimal quality of oocytes are having higher number of, chromosomal disjunction errors. And that's because of low ATP available for them. And when there is improvement in the mitochondrial DNA integrity, it actually results in decrease in free radical and but also lowers the rate of disjunction errors. In addition to that, since these people, since abortions are a distressing, especially recurrent pregnancy losses are a distressing condition and highly frustrating for both the clinician as well as the couples, it's important to treat both their stress, anxiety, and depression. And our studies have shown that you can actually increase the levels of various factors which promote neuroplasticity. You can see that brain-derived neurotrophic factor, the DHEAs, which is a brain vitamin, the factors which are the feel-good factor, the serotonin, the levels increase, and also the levels of melatonin, which is not only a potent antioxidant found in the mitochondria, but also helps to maintain the circadian rhythm. Its level increase. And this is also very important for maintaining the normal, the hormonal cycles which are being secreted along depending upon the circadian rhythm. So thus, I would just like to end by telling you that paternal factors play a critical role in embryonic viability and developmental competence. And oxidative stress, oxidative DNA damage to the sperm, dysregulation of the sperm transcripts actually result in miscarriages. And the practice of mind-body intervention, which targets both the mind and the body, like yoga and meditation, can positively impact both your mitochondrial and the nuclear genome, decreasing oxidative stress, decreasing DNA damage, maintaining the length of the telomeres, and normalizing the sperm epigenome, and thus would be vital for decreasing the incidence of miscarriages. Thank you.
Thank you, ma'am. Can we have the next speaker, please? Dr. Natasha.
Yes, it is an honor to invite Dr. Rajapriya ma'am, who is a managing director in Srinivas Priya Hospital Om Fertility Center, Chennai, Tamil Nadu. Ma'am will speak on a very challenging but yet very promising topic of ART in advanced aged females.
Thank you so much. Thanks a lot to Fertivision team for having given me this opportunity and also this interesting topic on ART in advanced age female. Now, as for a long time, we have known that traditionally the age of marriage and the age of reproduction in India has stood different, and we have stayed away from the rest of the world. But with westernization and modernization, things have changed. And in a huge study of almost 10,000 couples, even for a couple not intending IVF, if they decide that they want a single child, they should start as early as before they are 32 years of age. So there's a lot of link when it comes to women as to what her age is and what is the probability of getting a child. And this particular Habama also made a statement that if they are aiming for 3 children, they should marry as early as 23 years and start trying for the baby. So leave alone IVF. If you want to have a child, then the age statistics is completely different. On the other hand, if you look at the modern woman, she's a person who's multitasking and looking for gender equality, equal opportunities even in the work zone. She wants to be financially secure and independent. And her power of empowerment is reaching as much literacy as possible and set and achieve career goals. On the other hand, what happens in a country like ours? We see sex and marriage and having a baby in a completely different platform. Marriage is seen as a passport to be able to have sex as well as to attain parenthood. And this just has to happen on time for every family. So the girl has a tremendous pressure to match her goals and the plan of marriage. And even if she agrees to marry, there are so many other things which stay as hassles. For India, you know how horoscope is such an important thing to decide marriage. And sometimes it can delay marriage. Sometimes it is like everything is looking good, but the horoscope is not matching. And look at this, the Kundli matching is at time to tally of almost 36 points, which is a huge challenge. Now, what about the situation in each house? Not all can marry when they are 19 to 25 years. Today, the woman is ready to think about marriage only around 30 years of age. What if she's a sports person? She might have her dreams of getting into the Olympics. What if she's an actress? The minute she gets married, she loses her chances in filmdom. What about being a head of a big family? She may be forced to lead the family and be the financial provider. So the demanding careers, professions, and what about doctors as such? By the time we finish our course, it's quite a lengthy course. We may not be in the game at all. We may turn already more than 30, but we still want to marry at a point when we are ready for the marriage. So financial stability, and the huge thing is, I am not ready now, is a challenge. And once she becomes eligible, there's so much of things with respect to the age. Inevitably, in our country, we cannot accept a younger man marrying an elder woman. So the age is a huge detriment here. And even if the marriage happens on time, say by the time you're 30 years of age, not all can have the baby on time, but the fertility potential of 19 to 24 years is there. The husband may be head of a joint family. He may have his financial commitments which he wants to complete before he wants to become a father. And if it's an azoospermic or a low profile sperm profile husband, he just doesn't want to accept and act on it. Sometimes it's 5-10 years of marriage gone before they take decisions. Sexual dysfunction, which is undisclosed, is again an issue where the woman keeps getting elder. Trying naturally when it is absolutely not possible, again, delays prompt ART, and we are forced to deal with elderly women. And what about difficult relationships when she's not sure whether she should have a baby, then long distance relationship and impending divorce. Now, keeping all this in mind, the human body doesn't know, the clock keeps ticking. And we all know that by the time she's 35 to 37 years of age, her follicle pool is just 27,000 and the optimal fertility period is lost. On this particular interesting survey, Infertility Sterility shows, why is it that women are actually delaying childbearing? Why is it they are delaying the opportunity of marriage? Why is it not happening like before? Because of a lack of suitable partner, professional reasons, financial reasons. They find marriage and childbearing, both of them, as tremendous commitments. So that's one reason why egg freezing became a talk at a point. Now, why is ART in elderly women taken as a special category? Because of the higher risk of aneuploidy which the eggs carry, passing genetic conditions to the offspring. There's also a higher risk for miscarriages. Even if she gets spontaneous pregnancy at the age of 40, there's a high risk of miscarriage. And by the time she touches 45, even if she becomes pregnant, the miscarriage rate is as high as 75%. And this is an important point which we should help our women know. And in the bargain of doing ART, the higher order multiple pregnancy is a risk because we just don't restrict to putting 1 or 2 embryos. We want a pregnancy at some cost, so we tend to put in more than 3 embryos. And we should also remember to discuss multi-fetal reduction in case we have put in more than 3 embryos. A maternal health problems, if she's say around 45 to 50 years of age, sometimes they are obese, diabetic, hypothyroid, have hypertension, and you don't know what not they have. So tremendous comorbidity factors are there in today's modern woman. So the ART facility must be able of handling these kind of women and their special needs, which may be a donor egg or a donor embryo, etc. So each center must have their selection criteria for eligibility to enroll into the ART program, of which financial resources is very important because it is not going to just end with a routine 2 lakh package. It may go much more. It's not just about getting her pregnant. It is about taking her to the point of a live take-home baby rate, which NICU cost. All this should be discussed. If it's multiple pregnancy, all the more cost and more interventions. There's going to be cerclage and drug consumption during the pregnancy is going to be high. So it is important for us to keep all that in mind and counsel. So pre-medical screening is important. What about the life expectancy of both partners? If they have comorbidity, you need to understand she can't give birth to the baby next year and die the very next year. So keeping this in mind, a legal guardian consent and clarity should also be in place. And if you think she has some reason to meet with a fetal medicine doctor to understand that this pregnancy, as advertised by a lot of IVF centers, is not going to be an easy job. You just can't come, pay, and go home with a baby. Things can happen at every step in the wrong direction. So that has to be told. And we all have our own thinking. Pregnancy and child rearing by older women are seen by some as gross, unnatural, and selfish. Now, what about regulations in India? How old is too old to give birth? There's actually no law currently. But we do know there's a lot of talk happening in the parliament, and the draft of ART bill in 2017 put in an age limit as up to 50 years you can allow a woman to go through an ART program. And we need to make these women understand you're taking more risk, but for less benefit. Round about 35 years of age, then there's a take-home baby rate of around 42%. But what if you're over 40 years of age? It tremendously drops to 10% and even 5%. And sometimes women are shocked when I tell in my clinic that this is your chance of pregnancy. They immediately quote, no, I saw an advertisement saying that it's a 100% take-home baby rate. And then probably you have to be able to tell them boldly and transparently that that is not the truth. And if she still insists, she is welcome to go to that clinic which promises her that 100% assurance. So ethics and reality should be in place. There is no assured therapy actually. Sometimes the women ask, can't you make my egg quality better? Can't you make my embryo better? There is no assured therapy to say that. The truth is the IVF success rate drops with age, and the drop is tremendous with the crossing age and more than 42 years of age. Most of us realize it's a futile exercise with her own self gametes, and probably it's a strong point to talk about donor gametes. So let's have a checklist when we are dealing with the AMA group. The selection criteria should be satisfied. Did they go through the counseling and understand what's at stake? What about, because if you have not done it right and if the result turns negative, she's grossly upset that all her money went down the drain. So paperwork and documenting her success rate and penning it down is a worthwhile exercise and would make them think many times before they sign up for the program. And at the end of the program, as a clinician, you should not feel stressed out because you enlightened her on what's at stake. So personalized plan to do your best once you've signed up is important. The options of donor egg and donor embryo also should be there before she decides for her own gametes. And at the whole point, there's no point in making an OHS situation elderly woman. Sometimes she might have a tremendous reserve. So keep that in mind. Maybe she came up for the program late because it was a male factor. So, and even multiple pregnancy. We need not dare and put in more than 2-3 embryos when it is not warranted. So what about the stimulation strategy? It should be tailor-made, keeping the AMH, AFC, and FSH in count. We should be able to get as much eggs as possible. And there's no point pumping on with gonadotrophins more than 450 units. So there is a logic of how much of FSH and LH you're going to use. There were papers and systematic reviews and meta-analysis which came in saying addition of recombinant LH is worthwhile in elderly women, especially if they're over 35 years of age, and giving it in the ratio of 2:1. And today, some setups use recombinant LH of anywhere between 75 to 150 units as recommended by this interesting paper. And there are some clinics which try mild ovarian stimulation. End of the day, you're able to see an AFC of only 2 to 3. Whatever you pump in, even 450 units, you're still going to get 2 or 3 eggs only. So mild ovarian stimulation is also thought of. And nevertheless, this issue is still controversial. And the Poseidon also came with recommendations that no benefit in pumping too much of gonadotrophins. So there was this concept of why don't you do oocyte pooling or embryo pooling and then plan the transfer, because at least 2 or 3 embryos should go in once she crosses 40 years of age. And there is also the novelty of the dual stimulation, keeping the ovarian follicle wave pool theory and luteal phase stimulation per se. However, all this are needing further studies, more RCTs to demonstrate their clinical efficiency. End of the day, we are very clear, we need to have enough oocytes, not only the quantity, above all the quality matters. Next comes the phase when the eggs are there and the sperms are gone and ICSI has been done. Just by morphologically selecting the blastocysts, we may not be able to win the game. Genetic competency is important. So that's where the PGT for aneuploidy screening came in, and the bold move of even a single embryo transfer, because at 40 or 45 or even 50 years of age, she cannot be able to raise 2 or 3 children at a time. That's such a challenge. Those who have children know that handling one child in the house is enough of a nightmare, especially in COVID times. That was a huge thing we had to face. So the advantage of a euploid single embryo transfer, particularly at the blastocyst stage, is as good as a double untested blastocyst transfer. So the expertise of the embryological team is so important, how these gametes and embryos are manipulated and handled in a safe environment. So again, this shows that as age advances over 45, there's a huge drop in fertility and a huge risk in spontaneous abortions. And PGTA makes sense as an offer if the particular center can give it. However, is the additional cost justified is what we have to look at, because embryo aneuploidy is on the rise, and even in spite of ART, and live birth rates also decline. If the live birth rate possibility, which we have to transparently discuss, is just 15% in those at the age of 40, and just 1% if they cross 45 years of age, if they are going to try with their own eggs, because embryo aneuploidy is inevitable. And this is an interesting paper in 2014 at Iran, where clearly you just look at the 42 age column, there's a very poor outcome, practically 17% cancellation, and they actually set a limit that if a woman is more than 42 years of age, it is futile, because over 45, so beautifully they put everything as 0. So that is the situation. Why waste money? So the mathematical model which came out was, if a woman is more than 35, 38, 41, she needs at least 5, 7, 10 or 20 oocytes to be able to get one euploid embryo. And then comes the attractive option, donor egg bank. So what if you're old? You can use young woman's eggs and get a much better outcome. And probably we need to be able to discuss this at 40 years of age, because for some, religious and cultural sentiments may not allow. For some, they are so aggressive on their genetic offspring, but it is sense to discuss it for better results. And however, just because the technology is available, we can't misuse it or unethically used. And we had a scenario in 2015, 2016 and all, when grandmoms were becoming mothers. A 72-year-old Dalinja Kaur became a mother after so many years of menopause, because we can revive the womb at any time with HRT. And there was Rajo Devi. She was one of the first cases at 70 years of age. In 2006, she became pregnant. And this became like a benchmark for some elderly women who walked into our clinics and said, I'm just 55, why don't you offer me IVF? So we need to say the potential medical problems which they may endure during pregnancy and the best interest of the unborn child is to be kept in mind. Just because we have 1 or 2 of these miracle women, this can't keep happening. And in October 2020, Raja died of a heart attack at the age of 84, and his wife, Mangayamma, she's supposed to be India's oldest mother. And she said she was able to handle the grief because she had her twin daughters. I'm sure when these daughters grow up, they are going to curse the woman, why you brought me into this world? You have no right. And this is happening these days. Women are suing at an age when they realize that they should not have been brought into this cruel world, and they don't deserve to go through what they are going through. So as doctors, it is important that we cannot put these elderly women into a deadly venture, because the human body changes with age, and pregnancy can make it still worse. And so many complications are there: first trimester miscarriages, obstetric risks, the placental disorders, preeclampsia, gestational diabetes, and the babies can go through congenital anomalies, preterm births, stillbirths, low birth weight, IUGR, and obviously a risky cesarean section. So pre-existing comorbidities, we should be able to discourage these women that it is not worthwhile going through ART and a high-risk pregnancy. So physicians and prospective parents do have a moral and ethical responsibility. There was an interesting study in Japan in 2017, which started looking at advanced maternal age and advanced pregnancy outcome. And the same year in Canada, an interesting study came where ethical and medical considerations were highlighted. So it's time for us to understand that if she's too old to use her own eggs, social egg freezing is important. And those who do not want to have a baby by the time they're 25 to 26 years of age, they want to postpone it for a particular period of time, or they're not sure, social egg freezing has been approved by ASRM Ethics Committee. In fact, the social egg freezing has been renamed as elective egg freezing. So the consent, legality, and funding differs country to country. And again, society's outlook also keeps changing country to country. This interesting paper in July 2021 said social egg freezing, you can put a pause button on fertility. And we have to understand women have a right today. They want to go ahead with so many things, social life, social alcohol. They want to do social egg freezing as well. It is her reproductive autonomy, and it is actually a good strategy against age-related infertility. But this is for a select. We need to again have a selection criteria very clear. That's why elective oocyte vitrification is seen as a normal ultra-rapid freezing technology, where realistically, again, we have to tell her that 4 to 12% only is the pregnancy rate per vitrified oocyte. Probably it's an insurance policy to ensure that if she wants to have her children. I wouldn't say not for an elderly age group, because egg freezing is recommended before they attain 35 years of age, because only then it is a worthwhile exercise. Now let's look into the end of the presentation. How old is too old if you decide you're doing ART for an advanced maternal age? Counseling is so important, and we have to understand if they do not have enough funds, if they have all their life fought for it, it's time for us to tell enough is enough. You don't have to do any more treatment. To be child-free is not wrong. To be infertile is no longer a stigma in today's society. If we have decided she's a good woman, her finances are there, she has understood her results with her own gametes, just maybe 5 or 10% is possible. She's in good health status, nothing wrong, but let's go all out to do a personalized stimulation program, get as many oocytes as possible, make sense in embryo selection. If possible, she's ready, offer a PGTA and go for a blast. And selective oocyte freezing should be encouraged for those women who have a low reserve or who have big ambitions. It's not wrong, but it has to be done by the time she's 25 to 35 years of age. No point in offering it at a much elderly age. Egg donation is an excellent option once they cross 40 years of age. And embryo donation, again, is a beautiful program where low-cost services can be done for those who can accept an adoption, but adoption facility is just not available in the near future. Embryo donation is a good option. End of the day, fertility clinicians should follow regulations of the land, and they have an ethical responsibility. Just because the technology is available, we can't do it. We need to understand it is in the larger interest of the society. So the resolution of this issue finally is so difficult because there is a conflict between the couple's rights versus an unborn child's protection. So maybe a 50 years age cutoff as set by the government of India is a good thing to look forward. And we hope that regulations for ART clinics will come in place soon, with the bill becoming a law. And preventive education, it is time for us to get into our schools and colleges and to talk to young boys and young girls alike that it is important to establish a family as much as a career is important. And particularly young girls should be made to understand that there is a limited reserve of follicles in the ovary and it is going to fall. And if she wants her own genetic offspring, all this is important. So our reproductive health education is also important, and hope our policymakers impregnate it into their regular school education. End of the day, outlook of the society must change. Just because a woman couldn't get pregnant on time, or just that pregnancy is not happening in her life, we should stop being judgmental and understand that is a very personal thing what they are going through, and respect women, whatever be their age, that gender equality is important, so that she would not delay her childbearing when she could have very well had her baby when she was 30 to 35 years of age. She need not push it in the fight to achieve her education or career goals. And if we are having our reproductive health education in place, we will be able to do a great job that we do not get caught into ART in advanced maternal age, and we will be able to do good service for the deserved select candidates. Thank you so much for this opportunity. So this is a slide that just sums up saying how we can prevent the whole scenario, how we can kind of bail out of the scenario, how we can solve the scenario, and at the end of it, we really have to do it. How best can we do it?
Thank you, ma'am.
Thank you. Thanks to the timer, I just bailed myself on time.
Absolutely, ma'am. Dr. Uma, please take up the questions for Dr. Yadav.
Yeah. Thank you. At the end of this session, we have question and answer round, and I can see in the chat box there seem to be no questions from the audience. However, we have several of our own, and I hope the speakers are around to answer them. Dr. Yadav, if you're there. Yeah. So your talk focused a lot on the pre-stimulation period, wherein there are different influences on oocyte growth and its development. And how, and these are the important period of 80 to 90 days you mentioned before these eggs can be retrieved. And and of course, you mentioned about several correctives like diet and meditation and giving up smoking and all those lifestyle changes. My question to you was, what is the, let's say all of this was right, how badly can, let's say, a bad stimulation actually, and what is a bad stimulation, can alter the outcomes of IVF? And would this be different in different response categories, low response, average response, or high response?
Yes, that's a very, very interesting question. So one study I did on the factors affecting fertilization, and that was published in the Human Fertility, the British Fertility Society journal. And we categorized the factors affecting fertilization rate into three categories: the category due to the egg problem, due to the sperm problem, and due to the environmental factors. And environmental factors covered rest everything except sperms and eggs. And we see actually there is a very strong evidence that this environmental factors, that the lab, that all the lab conditions, the person who is doing the ICSI, everything has more stronger correlation with the outcome than the baseline eggs or sperms. And I mean, although they do have the contribution, and that's why I was giving the analogy of baking a cake or cooking a curry or something, as like the cook is also important as well as the ingredients. The problem here is I'm not talking about the patients which are box standard, like you're doing IVF for tubal factors or something as a male factor or something, young healthy young woman, and we are doing for some as a straightforward IVF, because not all IVF centers follow a very standardized protocol. Now the communication is very, very widely available. Immediately the new trends are picked, the studies are discussed. But the bad stimulation is, for example, sometimes certain drugs or certain molecules doesn't work very well. Giving you a very specific example of SER discs. If we have a high estrogenic stimulation or high estrogenic ovarian environment, that is a precipitating cause for the SER discs. So if your embryologist comes back and says that, look, hang on, the eggs were having a more SER disc, for that patient subsequent cycle, we ought to then think that what exactly we did in the stimulation protocol and whether there is any room to change that as a high estrogenic environment into the low estrogenic environment, or whether we're using high dose of drug than actually it is required. Right. And this is what I mean in terms of the stimulation or the protocols. And these are the specific patients where we are really struggling with the quantity or quality. I mean, quantity, you heard a very nice presentation just now, but this is, and the other presentation was also focusing on those things. So that is what I would put it, not really as a bad stimulation, but something we could have done better in the stimulation or in the protocol. Choosing the right protocol is very important for the right patient.
Thank you, Dr. Yadav. do any of the other chairpersons have a question for? Because I can proceed with Dr. Reema then. Dr. Reema, we absolutely loved your presentation. And of course, it's talking about the less talked about effects of sperm on fertilization, on subsequent growth of the embryo, on of course, the much later outcomes that would be probably manifest as childhood cancer. This was an extremely interesting talk. And you highlight that the importance of yoga and meditation on immediate outcome measures, which I saw through your presentation, were either looking at the fragmentation rates, which is DFI, or it was looking at the free oxygen radicals, or it was looking at. So my question to you is, what were the clinical outcomes in these trials, the ones that you undertook? And did it make a real difference to the patient in terms of, so one of the population groups you were studying was recurrent pregnancy losses. Did it really make a difference in terms of a live birth between the control group and the experimental group?
Yes, we studied, we had these two groups. One was the one which had gone in for assisted conception and had encountered 2 or more failures, and then the one who had conceived spontaneously and then encountered had encountered abortions. And we did find that when we have followed them up, even now we are in touch with our patients who are regularly doing yoga. Many of them have now had a child, maybe after say 14 years, after so many miscarriages. And we have a number of patients reporting back and telling them that now they have been able to have a successful, pregnancy after so many repeated failures. And when we look at back and now study the DNA integrity, and like I showed you, there has been an improvement. And since the damage is oxidative, not only is it improving this DNA and all, it's also improving the sperm motility, its fertilization capability also. So sometimes when there's an impaired motility and fertilization capacity because of oxidative damage, they may not be able to conceive spontaneously initially. Right. So that's sort of a natural, barrier to prevent bad DNA from getting transmitted to the offspring. So we have actually seen translationally that these people have had better outcome post, once they enrolled for these programs. But the important thing is that yoga should be done, firstly learned under a trained yoga instructor who takes their medical history, and it should be done on a daily basis. It's not like you switch on the television and you do yoga. When you have a designated time, maybe you do it for 20 minutes, but you do it daily. That's important.
Right. Also, of course, we have had this chat outside of this conference, but you do not point out to the importance of, or why people should not use antioxidants in order to improve the damage through ROS. And why is that? Benefit of
we don't say that don't use antioxidants, but there are several studies. You can see several meta-analysis also, which shows there's a lot of controversy that antioxidants on one hand do increase the concentration, motility, like E increases, vitamin E increases motility, C increases concentration, but at the doses where it is required to, penetrate the nucleus and positively impact the DNA integrity, those are very high doses, which at those levels, it can actually impair the capacitation and acrosome reaction. So it's important, and there are a few antioxidants which have been seen to impact the sperm DNA quality positively, but definitely there's a lot of controversy, and they say that the decondensation procedure is also also takes it's decondensation suffers post fertilization when you take high levels of antioxidants.
Okay. Dr. Yadava, would you like to comment on this? You had a slide on Cochrane synthesis of evidence of how antioxidants can help.
Yes, currently we are doing a study in Birmingham. Actually, Birmingham is a part of this study of antioxidants in the sperm, and our andrology department and andrology scientists are involved in that study. The results are not out yet, but the andrologist views on this are, they think, and this is, we always have this debate as well as always, but they say that it's just like any other medicine or any other intervention. If you are not doing in the right dose, right amount, and at the right place, then you always have the counterproductive effect as well. And they have seen that. They have seen the patients pumping in selenium and zinc, over the counter and then not seeing the good quality sperm. So we always take that history, we always cut that down, and there are now certain preparation because they are doing a study not only for the type of antioxidants but with the dosing of the antioxidants as well. So I will wait for that exactly, but the wait for the outcome of exact doses and the study and what they show. But many a times it's more of a logical approach. I would say that when you take the history and when you say exactly what the problem is, this couple is, what this man is doing, and whether this and it was really beautiful to see that how the yoga and all meditations etc helps, because I have put in slide as well meditation, and now most of the Western world is actually turning towards that. I had a couple who actually turned vegan as a proper British white couple who wouldn't survive without the meat from breakfast to dinner, went vegan, and they had success. And they always believe that success was because they changed their lifestyle, went to be a vegan and practicing meditations etc after multiple failed cycles. So that is good to see, but yes, this is what I would say, that not too much is not too good either.
Yeah, I would like to add something to this.
Yes, please.
We also did a double-blind placebo-controlled trial of antioxidants using certain antioxidants and certain herbal formulations. And what we actually found that though they were able to improve the motility and the fertilization capacity, but however, there was no improvement in the DNA integrity. And as Dr. Yadav said, indiscriminate use actually has it backfires, because it also prevents sperm from getting, adequately compacted, because that's required for the disulfide bonds to form. So that it has some physiological rules as well. And if you take it indiscriminately, like people do, even without your knowledge, they're taking so many antioxidants, it can backfire.
Dr. Ayyappan, I think your talk was very comprehensive, and it talks about all aspects of dealing with a lady who is above 40 and attempting conception. And it's not just the medical aspects that you cover so beautifully, the obstetrics part of it, of course, the social aspect and how best to deal with these ladies. We would like to know your experience on how you, whether or not you make any attempt to, while stimulating these women, to give any kind of measure for cohort synchronization, anything that is pre-stimulation measure, taking up from where Dr. Yadava left us.
I guess putting the three of us together was actually a nice session.
Yes.
At that age, we have two groups of women. One who has tried everything possible with a burnt out ovary, a very bad result, but I know I'm in for deep trouble. Whatever I do, it's not going to be a great program. So we always introduce, make sure her vitamin D, her vitamin B12, iron, folic, and a proper disinfection so that no fungal infection, all her comorbidity factors are correct. And I never do the program on the same cycle I counsel them. I at least give them 2 months time so that it sinks into their head that they are in deep trouble and they are asking for their own eggs in spite of a probability of only 1 or 2 follicles. Right. Whatever I do, I don't think I can make the 2 or 3 follicles become 5 to 10 follicles. On the other hand, I have another group, a group where they had postponed or they thought things would work naturally, or their finances didn't permit, or maybe it was a male factor, very severe OATS, and finally she decides, I know I'm in a good platform, but I 100% would do what they did. Make sure their micronutrient environment is good, their lifestyle factors are set, and any day ART in advanced maternal age is a challenge for the clinician and for the concerned couple, because everybody wants to pay to that one program and get away with a baby. There's not even a scope like you can talk about a cumulative pregnancy rate. So I make very, very clear your pregnancy rate is not going to be 60, 70 or 80%, nothing greater than 30 to 40% in the best of situations. So if that part is clear, then I would go, as I was just saying, I would tailor the stimulation. I usually go for an antagonist protocol. And I do not go in beyond, I would prefer using the human menopausal gonadotrophin. So I think I get the FSH and LH, because I end up in one of the peripheral areas in Chennai where the cost economics, it can't be more than 1.5 to 2 lakhs, the entire package.
Right.
So I don't have the luxury of the PGTA as well. So Pre-programming, meditation, diet, and acceptance of the reality. Don't get the heart hurt. That's what I would say. Don't burn your bank balance.
Yeah.
Limited resources, then we can wait for funds to improve and then do the program. So the mind would decide the success rate more than the body.
So just one last one from me, and the clinicians could perhaps take this. So out of the ones, the ladies who do make it, so we started off with that the women are interested in just one outcome is to have a baby, and the other outcome that will not happen is not have a baby. And that might mean that she may have been pregnant, lost her child. There may have been enough number of eggs, not being able to fertilize, not being able to, blastulate, not being able to reach the stage of transfer, and of course, not being able to reach the stage of implantation. So pregnancy and no pregnancy, or live birth and no live birth in women above 40. If we were looking at their variables, the confounders, what is the major difference that you see in women above 40, the ones who were able to make it, in terms of, let's say, the kind of infertility that they were dealing with, whether primary or secondary, duration of infertility, and if there were any other parameters that would help you determine that your individual chance of success might not be at 7%, it might be at probably 25%. So if you could just tell us, so it would help us in counseling our patients better. Dr. Yadava and Dr. Ayappan, please. Yeah.
Yes, so it's a very, very interesting. One of the paper I did was the strategies to improve the how to stimulate or how to manage the poor ovarian responder.
Yeah.
So it was a meta-analysis of, it was done, published like few years ago now, but nothing much changed since then. So we examined 10 different strategies, the antagonist versus agonist, GNI, addition of growth hormone, testosterone, DHA, everything, natural versus assisted, like stimulation, natural versus the normal, but we didn't find any significant or anything difference. Now this is about the studies. And the other model or other concept I explained is personalized medicine. So coming to your question, that it is a very, very important that we predict the personalized prediction to the patient. Now in the same clinic I said, and I say to patients that, look, this is the average. This is the good things on your side, that A, you don't have endometriosis, your BMI is normal, your lifestyle factors are fine, you don't suffer with any chronic inflammatory conditions. Although you are 41, but you have all these parameters on your side. So your prediction is higher than the, for all as a population. So the average number of, say, for example, if you want to give the statistical funny example, average number of eyes human have is less than 2. But because that's the average. So we are all are pretty much, many of them are better than average, because the average comes from the variations for somebody having some problems to most of them not having any problem. And this is very, very important for explaining patient about the percentage, because they hang on to the percentage. And this is how the personalizing the prediction. So we all see that even the pregnancies at later age or pregnancies earlier. And this is where, when the quantity is a problem, focus on quality is important. And another thing in poor responders, which I do in my personal practice, is mainly not how to stimulate is too important. When to stimulate is also important. And sometimes having that the right time, because we all know the antral follicle count changes at cycle to cycle. Some cycles are bad, some cycles are good. And that 1 or 2 eggs could make some difference in those patients. So we all have examples of 1 egg, 1 embryo and 1 baby, or 2 eggs, 2 embryo, or 2 babies, or 1 baby. So we all have seen the pregnancies do happen with less quantity, and this is where the focus on quality comes, and this is where the prediction comes. So personalizing prediction model is very important, and it starts from age, occupation, BMI, lifestyle factors, coexistent comorbidity, etc. That's the first part. The second part, from the last question about the risk and outcome you explained. Outcome is, yes, live, young, healthy baby is one outcome. Unfortunate outcome is miscarriage. Another outcome is having the preeclampsia, diabetes, all other pregnancy complications. Everything depends on the early placentation. And this is where we all need to be focused upon, because we have, again, more disconnect. In India, it's not that much of disconnect, but in Western world, it's a very much disconnect between obstetricians, gynecologists, and reproductive specialists, because they only do that stuff. And managing those pregnancies with preventative measures for obstetric complication is important, because that's the worst possible outcome, is losing baby and having sick mom. But these are the outcomes, and these are the outcomes with increased maternal age. And this is how I would put that, why the qualities then comes more important, and every step to do in this poor responder group, and when to stimulate.
I think I would agree with Sir on his views. See, there are two ways of looking at it. One is predicting ahead of time. And if you're lucky and you predicted a good IVF success or even a low success and it happens, all is well that ends well. But when the prediction goes wrong, or it's a great lesson. The very first cycle we have done is a great lesson. We get to understand how the stimulation went, how the egg pickup went, what are the quality of the oocytes, the embryology report, was the transfer smooth, all this information, whether sperm factor was there, so that when it doesn't go in her favor, when something goes wrong, like whether the pregnancy didn't happen or whether she had a miscarriage, there's always a what next till she gets the baby. So at that point, we probably have more room to introduce the concept of the donor egg, and if her finances are bad, for a donor embryo, because we need to see what it is. But I have had the heart to even say stay child free, because in India, the funding is a huge problem. How many ever cycles, it is she who has to fund. And at an elderly age, to make this tremendous effort, they would have pooled in all their resources. So I would always try to time, as Sir rightly said, to time it. You just can't do the ART the very cycle they come into. You need to make them wait, prepare them, personalize the program, time when you think you're going to get the best outcome. If it works, fantastic. But if it doesn't, we need to be able to give them the next better option. We need to improve on the previous program, right from stimulation to probably bringing in donor egg or a donor embryo. Or if you think the endometrium wasn't good, whether we need to revisit the uterine cavity and things like that. But if finances are bad, then we as clinicians should ethically stand up for her and tell her it's okay. To hell with society, you do what is good for yourself. Or if she's a very bad candidate, to go through the whole program again. Again, we have to be brave and tell her that the pregnancy may be very stormy for her. She will fall into the high risk category.
Thank you so much, ma'am. With this comment, with this discussion, we come to end of this session. I would like to thank all the chairpersons and speaker for making us much more wiser. And from here on, we move on to the oration. Thank you so much.
Thank you so much for the interaction.
Thank you. Thank you, everyone.
Thank you all.
Thank you.
Thank you.
The oration, you can log in with the Hall A link or the delegate link.
Hello, Dr. Roya. Hello.
Hi.
Dr. Zoya, Dr.
Yes.
Sophie.
Very good afternoon. Yes.
Hello, ma'am. Good afternoon, ma'am. We have oration in the other hall, Hall A. So that will be relayed in Hall A link. So I've shared a link in the chat. If you could see, you can log in with that and attend the oration. That's Dr. Rajmathu's oration.
Yes.
And ma'am, if you want to check your screen share, you can now do now.
Sure, we will do that.
Yes, ma'am. Stop share.
It's not moving.
Yes, ma'am. We can see it, and slides are moving as well. Slides were fine, ma'am. Thank you.
Thank you.
Yeah.
So, Hani ma'am, would you also like to share your presentation?
Can I do that?
Yes, ma'am, absolutely. Himanshu, please allow ma'am to share the
Yes, ma'am.
presentation.
Okay. Shall I select?
Yes, ma'am. You can do now.
Okay. Yeah, can you see it now?
Yes, ma'am. We can see it.
Okay. And so that's fine
Make
then.
it. Yeah, make it slideshow and try moving your slides.
Okay.
Yes, ma'am.
Yeah, it's doing that.
Fine.
Okay, so everything is fine. So I'll also join then Hall A, listen to
Yes.
the audition, and then come back.
Yes,
Yes.
ma'am.
Okay, thank you.
From this talk, I am looking
most people, which is related to some.
Himanshu? Himanshu, please let Dr. Anjana in. Ma'am, I can see you.
No, because this you have to give it to them. If you lock it, they will. This you have to give it to Ali.
Good evening, all. So for the next
It's 4
session,
o'clock.
we have with us Dr. J.K. Goel, Professor and HOD at Saraswati Institute of Medical Sciences, Hapur. Dr. Ranjana Sharma, she's Senior Consultant, Obs-Gynae, Indraprastha Apollo Hospital and Apollo Cradle Royal, Delhi. Dr. Manishi Mittal, she's Consultant Gynecologist, Mittal Maternity and Nursing Home, Yamunanagar. I welcome all the chairpersons. Now, please introduce our guest speaker.
Good afternoon, everybody. I feel pleasure in introducing Dr. Roja Royalty, that she is Professor and HOD Obstetricians Gynae, Sardan Institute of Medical Sciences and Medical Research. She is Director, MHRT Hospital and Research Center, Banjara Hills, Hyderabad. She pioneered the first delivery, IVF twin delivery in May 1997 and ICSI triplet in June 2005. She was accredited as a fellow of Royal College of Obstetricians and Gynecologists on 16 September 2005. She is member of Institutional Ethical Committee of Mahabir Hospital. She is convener and task force member of MCI committee for setting up rules and regulation for MCH. She is task force member of ICMR and many projects. She had been the IFS secretary, Telangana chapter, and she is convener of SIG endometriotic as IFS. She has got multiple awards and medals to her credit. Now I request Dr. Roya Rojati to go for her the talk on the stimulation protocols in severe endometriosis. Is there any difference? Dr. Rosa, please.
Thank you, Professor Goel, for a nice introduction. My sincere thanks to the President, Dr. Sudha Prasad, Dr. Nina Malhotra, Secretary General of IFS, and Professor K.D. Nair, our President-elect. My talk is on the endometriosis severe and the stimulation protocol. Is there any difference? Endometriosis, approximately 15% of the patients with infertility are being affected with this problem, from mild to moderate to severe. And it's believed that endometriotic lesion in the pelvis created a hostile microenvironment for the fertilization. It is affecting the fertilization of oocyte and early development of the embryo in the uterus and the fallopian tube. And endometriosis is also affecting the ovarian reserve and the responsiveness to the ovarian stimulation in any ART program. These effects lead to the lower fertilization and pregnancy rate and conception rate in patients with endometriosis undergoing IVF treatment, in contradict with the other indication for IVF like male factor or tubal factor. Always conception rate are lesser. This is probably related to the increased level of pro-infiltrative cytokines and the interleukins, abnormal oxidation damage to the ovarian follicles, resulting in the diminished oocyte quality, regardless of the stage of the endometriosis. In our experience, normally whenever we do the stimulation of these endometriotic patients with the IVF in IVF program, Normally, these follicles, it undergo atresis due to this apoptosis program, which is there inherent because of very complex pathogenesis. So in this long journey of these ART with these endometriosis, which is a very tough job, what are the molecules and what are the things and tools can come to the rescue and increase and improve the conception rate? So one of these molecules, which we had a long journey and long experience with, is gonadotropin LHRH agonist. Several studies exist which is comparing the reproductive outcome in patients with endometriosis undergoing ART treated with or without GnRH agonist. GnRH agonist will be started on the day 21 of the menses, and stimulation with the gonadotropins, HMG or FSH is initiated as quickly as possible on the early follicular phase on the day 2 or day 3, depends on what protocol you are following. And a tendency for a higher pregnancy per cycle is being observed in GnRH agonist cycle as compared to the cycle without any downregulation. GnRH agonist is initiated at the mid-luteal phase to achieve downregulation, and it is continued till the day of the HCG injection prior to the ovum pickup. Prolonged downregulation, it refers to the extension of the 2 to 3 months period of the analog administration used in so-called long, ultra-long protocol. And prolonged use of the GnRH agonist in women with endometriosis, it aims at inactivating or neutralizing the endometriotic implant, as GnRH agonists are known to interfere with the paracrine and endocrine factors which are involved in endometriosis. Women with endometriosis following prolonged downregulation with GnRH agonists are probably starting an IVF cycle with the disease which is under control and perhaps with the increased chance of the conception. The studies have examined the value of the prolonged downregulation in patients with endometriosis undergoing IVF. Studies reported that the higher clinical pregnancy rate per transfer in 21 patients with the various stage of the endometriosis who received GnRH agonist for 60 or more days before ovarian stimulation started, as compared to the other patients with the endometriosis who were treated with the standard mid-luteal GnRH agonist downregulation protocol. So 67% versus 27% in this patient result. So conception rate is always better in patients who have been using this LHRH agonist depot for a longer period. These two tables, it shows basically the ultra-long protocol versus the long protocol of the LHRH agonist before stimulation protocol. And we can see easily the 67% versus 27% the conception rate, which it is a big difference. So we can see the ultra-long protocol, if the LHRH depot is being used approximately 2 to 3 months before the ART and stimulation protocol, it gives a better success. The majority of the retrospective studies conclude that the reproductive outcome in women with the endometriosis undergoing IVF is improved after prolonged downregulation with GnRH agonist before starting the ovarian stimulation. What are the evidence from the prospective study? So far, we were discussing about the retrospective study. There are studies which has shown the ovarian stimulation for oocyte retrieval without any preparation. This is the group A versus 35 patients who underwent 6 months period of hormonal suppression therapy with GnRH agonist group B before the ART procedure. Patients with a severe endometriosis undergoing IVF reported that the use of the GnRH agonist for 6 months prior to stimulation 48 cycle as compared with the stimulation with the gonadotropin only was associated with a significantly higher clinical pregnancy rate, 25% versus 3.9%. So here you can see this table indicate clinical pregnancy rate. It is much more better if patient has used basically